Want the door closed. So, on behalf of ICON, I thank the organizers. My name is Viraj Lavingia, and my co-host for the GI session today is Dr. Vinayak Maka. For the next 4.5 hours, we have 3 debates, couple of talks, couple of how I treats, and couple of panel discussion, and we'll round it off with industry symposia. So without wasting much time, we'll start off with the debate session. Each debate is 30 minutes. The speaker 1 gets 10 minutes, the speaker 2 gets 10 minutes, and the 10 minutes is for the verdict. We have 3 debates, all 3 on colorectal. This is to make the subject even more confusing. So to start off, we have debate number 1. It is on rectal cancer. Is radiotherapy-free treatment a viable option? So can you do without radiotherapy for certain group of rectal cancers? For that, we have Dr. Sujana Priya. She is a radiation oncologist from Hyderabad, and she's gonna have a position of no. So can I have you here, please? Thank you.
So thank you, Dr. Viraj, and thank you for such a simple, easy topic. But the thing is, the statement is quite complex. So the statement, what I'm trying to debate here is radiotherapy omission. Does radiotherapy omission has a role in locally advanced adenocarcinoma? That's how I just simplified it. So before we go further, I believe you must have heard about the red herring story, but I'm not going to tell the story here because Vamshi is gonna not like it. So nowadays there is a season going on all around about a discussion about omission of radiotherapy trials. So a lot of trials have been commissioned to omit radiotherapy with a lot of conflated evidence. So talking about evidence, so evidence generation is usually done in 3 steps. One is evidence generation, which is done outside somewhere in a very controlled setting, in a trial setting. And the other 2 steps, evidence interpretation and evidence communication, is very, very important. So these are the 2 steps which are very important because that is what you're going to apply in the clinic, because not every patient goes in a trial. So whenever there is some form of miscommunication or misinterpretation of any particular trial, so this is what happens. This is what happened last year when the Prospect trial actually was published in New York Times, and there was a lot of rebuttal and backlash from a lot of radiation oncology communities all around the world, and eventually it led to coining of a word called radiophobia, so which is fear of radiotherapy, which I'll tell that there is nothing to fear about it. So having said that, we all know about this landmark paper, the German trial, which kind of established the role of and consolidated the role of neoadjuvant chemoradiotherapy, way back published in 2004. I agree that in a scientific background, you always should question the dogmas which are there. So as a pro-scientific person, always that's always what we suggest to do. So eventually a lot of questions have been put forward, whether to omit radiotherapy and how to go forward. So these are the few trials which are going on all around the world, the FORWAC trial, the CONVERT trial, and the upcoming NEORT trial. So now we are going to dissect the Prospect trial and see what it says. So because we don't have so much time, so that's the reason, and it has created a lot of furor all around in the community. So that's the reason I chose this Prospect trial. So in the MRI era, we are talking about radiotherapy omission. So based on a lot of landmark trials, based on MRI landmark trials like Mercury and Occam and other trials, if you look at carefully, so they have clearly chosen a very good cohort of patients, the T3N1 moderate risk patients, especially in the Prospect trial. There was no representation about high-risk patients at all. And looking at the CONVERT and FORWAC trial, at least 1/4 of the patients, they were high-risk patients, but not completely omitted from the Prospect trial. So this is how the trial schema looks. It is compared with the standard arm, combined modality arm, the 5FU-based chemoradiation, and along with FOLFOX, upfront FOLFOX for 6 cycles. So even then, if you don't have a very good response, if your regression is less than 20%, you still say that, array, please give radiation. So that is how it's going on. So this is like this. We can't let you go off. We are still there. We are just holding you, buddy. Please don't go. So just in case if our chemotherapy doesn't work, we'll definitely need your help. So that is what. So intolerance to chemotherapy is one way to look at it. And if your response is less than 20%, and post-op resection rates, if there is R1 or R2 resection, then definitely, which has already been wiped away from the face of the earth, nobody is doing post-operative radiotherapy. Even then, if you give FOLFOX, if you have R1 resections, then definitely you're going with post-op, which is probably not a good thing to do. So whenever you write a rationale for the trial, so the first thing is, why are you going to omit the already established standard? So why do you have to omit? You have to write a detailed page of rationalizing your argument. So here there are multiple irrational arguments rationalizing using FOLFOX. That is what they have written. So the pelvic radiation, they were talking about toxicity and duration. Come on, which year we are in? We are in 2024 and we are talking about all conformal techniques, proton, ion therapy and everything. So obviously the toxicity is going to be definitely less. And the duration of treatment, we have clearly chosen a very moderate risk patients. We are really not going to miss the bus by talking about micromets in this particular setting. And also, we can probably get away with short course radiotherapy in this particular treatment. Now, coming to the pregnancy and childbearing, this is the poster statement for this particular trial. So of course, don't you agree that chemo also affects fertility? Chemo also has some sort of gonadal toxicity. And of course, if you look at the PRO, the patient-reported outcomes, there is no mention about the reproductive function. There's a lot of mention about the sexual function being deranged in radiotherapy arm, but there is no mention about the reproductive potential. So looking at the surgery and the systemic treatment, they said it has substantially improved. Techniques have come into play. So is radiotherapy. So radiotherapy also, the techniques have really improved a lot in the last few decades. So impact on fertility, we already spoke about. This is the data I have pulled out. Definitely chemotherapy has an impact on fertility. I don't think you disagree with me about that. So now looking at the end staging. As you know, end staging is very, very imprecise. Very, very imprecise clinically when you're doing a clinical end staging. For all you know, this could be an N0 disease. And they've clearly picked up only 1 to 3 nodes in the mesorectum and they said, okay, these are the patients we are choosing. So compared to the 7th edition, if you look at the 8th edition, there is more precise end staging, like N1A, N1B, and N1C. It has been proven time and again in numerous trials and studies that 7th edition end staging is imprecise. That is how we chose 8th edition end staging. So now, are we still justified in using the old 7th edition end staging and asking the patient to go ahead and take FOLFOX? I don't think that's a good idea. So this is one interesting trial showing that the risk of relapse, be it local or distant, depends and is a function of T and N status. It's been published long way back. So now toxicity profiles. If you look at the trial clearly, almost 1/3 of the patients had definite dose reductions, and peripheral neuropathy is the most common cause which has been gone beyond a year or so. So diarrhea is the most common complication in radiotherapy arm, but it is mostly in the acute setting. Even grade 3 and grade 4 adverse events are definitely 1/3 in a radiotherapy arm. I do agree with that. So one beautiful thing which they have really done well with this particular trial is documenting the patient-reported outcomes, which is very good. So these are the patient-reported outcomes which have been clearly documented, and a separate paper has been published about this. I'm not going to read out, but FOLFOX arm has got more of these patient-reported outcomes in a worse fashion. So now looking at the other things, the bowel and sexual function is definitely better in FOLFOX arm compared to chemoradiotherapy arm, but the quality of life is definitely better at 12 and 18 months. So is omission of RT an option and you want to treat this patient with chemotherapy and take the FOLFOX route? I don't think that's a good idea, because this paper says that there is better autonomy with radiotherapy at 3 months after surgery, definitely. And also the depression rate and all the IADL, the instrumental activities of daily living, is better. So in fact, obviously more than 70 years, you'll be very guarded in offering any patient chemotherapy, isn't it? So then the only option would be radiotherapy left. So now coming, this is a real world scenario which we got in the clinic. So you can see a very nice proliferative hemicircumferential growth in the rectum. So this has been reported, it's in the upper and mid rectum, reported as a T3B N1, which clearly suits the prospect guidelines? Are we really going to, somehow we had a discussion in the MDT, we thought the only criteria when we push for surgery is we don't want to treat the patient in a post-operative setting. So we thought this patient will definitely not go ahead and receive post-operative radiotherapy. So we push the patient for surgery. So this is the final HPE, which is a T2N0, which becomes a stage 1 eventually. So giving FOLFOX would have been an overkill as per the prospect trial. So few setbacks. Just now we were discussing with Dr. Amish Vora outside. So the T4 tumors and distal tumors have been eliminated in the trial. The positive CRM and sexual function, like I said, has been assessed, but there's no reproductive function assessment. So there's a lot of diversity and underrepresentation of our set of populations, all based on Caucasian population. Can we extrapolate is the question we have to ask ourselves. So in moderate risk patients in an era of de-escalation, so most of the trials we are extrapolating from the colon and putting to rectum in extrapolation. So in an era of de-escalation after the IDEA collaboration has been published, are we still justified in giving 12 cycles of FOLFOX? Because 85% of the patients in this trial has received 6 more cycles of FOLFOX even after surgery. So are we justified in doing that? That is the question we have to ask. So of course, trial setting is definitely not a real world setting. Chemo-induced liver toxicity could be this bad. And eventually the patient is going to miss the primary modality of treatment, surgery, which is probably not a good thing to do. So to conclude, it is critical to treat, but definitely very important not to overtreat any patients. You need to have a detailed discussion with the patient about the patient reported outcomes and other things. So omission of RT trials, there is no or almost underrepresentation of lot of high-risk rectal cancer features. So that's the reason you need to tell the patient that yes, just in case you might be needing, if the chemotherapy doesn't work, you might need radiotherapy eventually. And also all high-risk rectal cancer patients definitely has to take the route of radiotherapy. There is no doubt about it. So thank you for patient hearing. I would like to thank you, Dr. Vamshi, for giving me this opportunity. Thank you once again.
Now I would like to invite Dr. Amish Vora to have his position to say, yes, we can omit radiotherapy in certain locally advanced rectal cancers.
Thank you, Dr. Sujana. It was a very, very nice and eloquent presentation. So the point here is, before I say, I would like to say that everyone who has read about Prospect, the lead author was Dr. Deborah, and she has given a very good 2-page summary or the explanation why did they take this trial. I think we all have to go through that when we understand that what was the need of omission of radiotherapy. And I would like to point out just one word in the title: is this a viable option? That is what we are discussing. We are not discussing complete omission. We are saying, is that a viable? I am supposed to say yes. So before I go on the actual topic, I sincerely request, we all are taught to have empathy with our patients. Forget about cancer. I ask all of you sitting here, just think that if you have urinary incontinence, or if you have to go 20 times motions in a day, आप अभी यहाँ कॉन्फ्रेंस में बैठे हो, 5 मिनट में you have to go to the loo, come back. 10 minutes बाद again you want to ask a question, you go back and come back. I think, we all can think. You are not able to perform sexually. Now this function is spoken so little in India. We all know that we all shy away from talking this, but this is also one of the most important aspect of life. And if you're married, you're planning to have children and you are told, sorry, you are infertile. Again, this topic is important because in May 2021, US Prevention Services Task Force has reduced the colon screening from 50 to 45 because the young rectal and colon cancers are on rise. So, today's topic is this: why do we even need this path? We are very happy. As Dr. Sujana said, CTRT, TME, adjuvant chemo, lateral lymph node dissection, and the last and very important is total neoadjuvant therapy. Remember the figure 75% at 5 years, I'll come to that. We have been able to cure 3/4 of our patients. Are patients happy is the question we need to ask. So you tell patients you are cured of rectal cancer, congratulations. But you can have second malignancies to the tune of 10%. This is a meta-analysis incidence, not one paper. 1 in 10 will have second cancer. 33% will not have sexual function. 12% stricture, 13% bowel obstruction, 62% bowel incontinence. Remember 20 times, going out, coming, going out, coming. And frequent gas, urinary incontinence, pelvic fracture, DVT, etc., etc., etc. And these are all the words used by Dr. Deborah that why did they want to take up this trial. So if we empathize from patient's perspective now, from the rectal cancer perspective, patient asks, do I have an option of skipping RT when you're discussing so many side effects and still achieving cure? Of course, we can't compromise on cure. My answer till 2 years back was no data, but now we have data. So we always start with NCCN guidelines. Let's discuss locally advanced rectal cancer. We do MSI in all our patients. And then in dMMR patients, let's look at this. You have an option of giving only immunotherapy, and if there is a complete clinical response, there is a surveillance option. I can't see any radiotherapy here. You see pMMR. You have an option based on prospect. Now this is again version 1 2024 has exactly the same slides. You give chemotherapy. If the tumor regression is more than 20%, surgery, again no RT. What just happened? In 2003, Atul sir was my senior. If I would have told, sir, I can cure some rectal cancers without radiation or surgery, sir, you would have failed me in my DM exam. But we have to change with time. So 3 major practice-changing advances happened in last decade. TNT, of course, surgery can be optional here. Immunotherapy alone, again, surgery and radiotherapy can be optional. Prospect trial, radiation can be optional. This is a viability what we are talking of. We all know about dostarlimab study. We all know that now 30 patients from 0 to 36 months of follow-up, and majority of the patients are still in complete clinical remission, without surgery, without RT, without chemotherapy. TNT can't be ignored, I must say. 6 trials, concept very well proven, and as I said that majority of the patient have an option of not going for surgery. We cannot ignore this option. But TNT, the biggest criticism of TNT has been, are we over-treating some of our rectal cancer patients? And that is something which is important. And because of all these things, the NCI-led group came out with Prospect trial, that is the preoperative treatment of locally advanced rectal cancer. The standard arm is simple, CTRT, surgery, adjuvant chemo. The experimental arm had FOLFOX 6 cycles, restage, more than 20% response, do only surgery, don't give RT, less than 20% response, pelvic CTRT. Shah Rukh Khan's photo was shown by Dr. Sujana. Only 9% of patients require Shah Rukh Khan's hands, another 91% patient did not require. Every slide which she has shown, it requires merit, I must say that. But they were all conjectural and theory. Just look at this slide and you'll realize that all those theories were unconfounded for. Disease-free survival at 5 years in chemo alone arm was 80.8%. TNT, I said, 75%. Remember that. Freedom from local recurrence rate at 5 years. This is something the radiation colleagues will keep on harping. Local recurrence, local recurrence, local recurrence. 98.2% in chemo alone arm are free with local recurrence. What are we looking at? Let's look at disease-free survival, exactly same. Overall survival, exactly same. Freedom from local recurrence also exactly same. Moving little bit away. Now this was, again, Viraj told me yesterday, so I looked up this slide. January 22, 2024, colorectal cancer, GI ASCO. 12 patients of proficient and deficient. We kept talking about pMMR, no immunotherapy. This is a proof of concept study, 12 patients out of which 4 patients were rectal cancer. DMMR 100% response rate, 1 patient was 98% response rate. PMMR, 2 patients had 100% response rate, 1 patient had 98% response rate. Proficient MMR report and the combination of IO plus IO giving 100% response rate. This is where we are moving forward. So what do I conclude here? There is no right answer. As I always say, and I'm sure Atul sir is also going to say the same thing, but sir's choice. Individualized treatment decisions are going to be the future. I am extremely happy Prospect has given us the power to discuss with patient. Then in a select group of patients, you can have either TNT followed by surgery, TNT without surgery, only surgery, T1, T2, you don't require anything else. Only immunotherapy, chemo followed by surgery, all options are correct as of today. But 2 things are for sure. Rectal cancer can be cured without compulsory surgery or compulsory RT, and the treatment of rectal cancer without RT remains a viable option as of today, 2024. Thank you so much.
We'll call a speaker to do a rebuttal to Sujana. And meanwhile, I would invite our chairperson, Dr. Ravi Kumar Saxena sir, and Dr. Sudha Sinha to be chairperson for the session. Please grace the. Go ahead.
Yeah. Thank you, sir. Thank you for a wonderful, debate. So every slide, whatever we have seen, sir is probably deliberately skipping a few lines what he has written, especially in the last slide. So I agree, but especially in select group of patients, this prospect kind of we can probably push, but definitely not in the high risk, because like I said, all the high risk patients have been deliberately put out of the trial, and all the intermediate risk patients have been put in the trial. So in that way, are we going to extrapolate to the whole gamut of prostate patients? Because you have from T1 to T4 with multiple prognostic factors like EMVI, CRM, and node positive, lateral pelvic nodes and other things. So I don't think we can probably just pass on a blanket statement telling that, okay, we can completely omit. So there are a few cases where you can omit. We also agree with that. But there are a few. The reason why I'm telling this is the message has to be loud and clear. Not all patients will be needing radiotherapy. At the same time, you should not pass a blanket statement telling that even for high-risk rectal cancer patients, you can just get away by omitting some form of local treatment. So that is the point I would like to make.
I would request Amish sir to rebuttal before Dr. Atul sir can.
And one more small thing.
No,
so
you got it. You closed it.
Oh yeah, you said 9.1%, but actually you have to count the 1.5%, so it totally makes around 10.5% because few patients have actually received post-op radiotherapy also. So the numbers are not.
I think I don't have to say anything in rebuttal, but one point which Vamshi just now told me, that I am for Prospect because my center does not have radiation. But I think, in fact, that brought me a very important point. Dr. Deborah also mentioned one of the point, that many parts of the world, the RT also is a scarcity. And this trial of 1,200 patients, it empowers you in selecting some patients for omitting RT. You know, I think that is one extra point which I would say. That's all. Yeah.
But infrastructure lack is probably not in India, sir. Not in India.
Dr. Atul sir, expert comment. Yeah, this is free to use, sir.
All right. So By just putting a simple word, probably, I feel that the debate has been tilted in favor of Amish. The viable, because I think so. I think everybody should agree that the idea is not to run down one specialty or another of this thing. So ideas in the medical oncology also we keep on trying how to minimize the long-term toxicity, minimum drugs and this thing. So probably they just tried the same thing. That was the whole idea and very well explained by Amish in this thing. It's written in the paper and this thing also. That is very well point, this thing. So personally, I say that this is a viable option. There is no confusion in that. And probably rather we should be happy that we have one more option for the treatment of the early rectal cancer and probably those who are eligible for the sphincter preservation. So that part is very well taken, and I probably personally, given a choice, somebody probably want to treat something, the eligible patient would go for that. Because always you have an option of the chemo radiation. If the response is inadequate, if you need margin positive, of course that option is there. And believe me, still many patients in the country, probably in Delhi, elsewhere and this thing, still they first go to the surgeons who will be operating upon and they end up giving adjuvant chemo radiation, this thing. So this is a valid point. So an idea is nothing like that radiophobia or this thing. We all are very probably learned or probably educated people, and this thing we understand. Yes, we understand it probably that what are the likely toxicity of each one and this thing. So this is for a very selected group of patient, and so that was the main point. And of course, probably now we have this thing. The new trials are saying that the surgery also can be avoided. And the NCCN about 2-3 years ago, even immediately after this thing, publication of the dostarlimab study and this thing, lot of patients asking whether they can avoid surgery or this thing. So this is probably one more feather in the armamentarium for the treatment of rectal cancer. And you raised the point that probably are we still using the previous, because the trial started that time, that was probably the prevailing staging system, so they are justified in that. So I say that this is not for everyone, one size doesn't fit all, and for if we are able to select a patient and this thing, then this is a viable option, and probably that's what I would like to say. All right, any other comment from the audience or chairperson or this?
I would request anyone in the house want to ask some questions for the, one thing good about debate is like the person who prepared for topic will be well versed in weakness. I think I request anyone, students or anyone can ask a question. We have 1 minute. I can take one question or questions. Either they understood everything or they are more confused. So with that, I think this whole session is skipping some modality. So now I'll call next topic. Challenging the surgical norm. Can wait and watch approach can be feasible? Strategy for surgical free treatment in locally advanced rectal cancer. There will be rebuttal no by Dr. Ashwin Desouza. I would request Dr. Ashwin Desouza to take the stage. Thank you.
Yeah, so thank you for this invitation. First, I'm very happy to debate with Reena madam because we have this fight in the OPD every day. So this is just like TMH OPD for me. We are discussing wait and watch, and I, as a surgeon, are going to tell you the argument against wait and watch. So it all started with Haber Gamma with her proof of concept when she showed 265 patients rectal cancer, neoadjuvant chemoradiation, 71 CCR, rest underwent surgery. And then she compared the CCR with the patients who underwent PAT-CR, and he said that with doing nothing, these patients are doing really well. So we can actually just observe them. That's true, but one point to take from this study is PAT-CR is actually not equal to CCR, seen by the survival data in this study also, and also by the fact that clinically these patients actually required surgery. PAT-CR is not only a function of the neoadjuvant therapy, but also of the difficulty of the pathologist in finding these isolated tumor rests in what can become a very fibrotic and dense scar. So for wait and watch, there are actually two concepts. One is the accidental wait and watch, where the neoadjuvant therapy is given to decrease local recurrence, and if incidentally you get a complete response, then maybe you can observe. But now today we have good MRI, and we can classify patients into good prognosis groups. And when you extrapolate this wait and watch strategy to this good prognosis rectal cancer, then we call it the intentional wait and watch, where the neoadjuvant therapy is given solely to achieve the complete clinical response and avoid surgery. But that being said, wait and watch can never be truly intentional, because no one can actually guarantee that one particular patient is going to have a complete clinical response. It is also interesting to note that with this good classification of MRI, in these good prognosis patients, if I operate them alone, I'm going to get local recurrence of only 3%. Now, in all the neoadjuvant RT trials, there was no MRI used at that time. So today we can actually classify a rectal cancer into good, the bad, and the ugly. So if you operate these good prognosis upfront, they actually do quite well with single modality therapy. The trump card of the radiation oncologist is this OPERA trial, which came out last year. And they say that, I'll boost up the radiation and I'll raise the organ preservation to unbelievable limits. That's true. But look at the inclusion criteria, right? T2, T3A, T3B, that is less than 5 millimeters extramural invasion, but that's not enough. The tumor has to be less than 5 centimeters. That's not enough. You have to have only N1 nodes, and that also the node less than 8 millimeters. Okay, select these very good rectal tumors, give them full radiation, but that's not enough. We have to give additional external beam boost 9 gray or 90 gray contact X-ray brachy. I mean, if you give so much of radiation for such a small tumor, and then you say I get 97% organ preservation for less than 3 centimeters, well, that's fine. But look at the fallout. 63% are having rectal bleeding for 3 years. 3 years. I think the patient ought to know about this before making this choice. You can increase complete clinical response by giving some consolidation chemotherapy, as shown by Haber-Gamma. Also from the MSKCC data, Garcia-Aguilar showed that you increase 2, 4, 6 cycles of chemo. After long course, you increase PAT-CR. Again, this is PAT-CR, not CCR. But then they tested this concept in the OPERA trial, consolidation versus induction chemo. Primary endpoint was DFS. This was a phase 2, 2 independent arms comparing with a common historical control. So they did show that DFS was fine, and organ preservation 53%. Long-term results also confirm organ preservation 54%. There is no doubt if you give chemo after long course chemoradiation, you are going to preserve about 50% of rectums. But let us look at this concept of consolidation chemotherapy in a little more analytical manner. So that is our standard schedule for treating rectal cancer: neoadjuvant chemoradiation with surgery for local control, the adjuvant chemotherapy to take care of our risk of metastasis. I wrote plus minus because the whole of Europe actually does not give adjuvant chemotherapy based on the EORTC 22921, but there were some flaws in that. This recent meta-analysis, which also looked at infusional 5-FU and oxaliplatin, did not actually show any OS or DFS benefit in radically resected rectal cancer with neoadjuvant chemoradiation. So there is a doubt whether we need that chemotherapy in the adjuvant setting. Moving on to colon cancer, as we'll see in the next debate, they're also scaling back, giving less and less adjuvant therapy. Now what consolidation chemotherapy does is pushes this adjuvant into the neoadjuvant setting using systemic therapy to get local control. And then if you do that, then you can avoid surgery in about 54%. That was the OPERA trial. I have no problems with this reasoning, but my only fear is there is a subgroup of patients, the T1, T2, T3A, T3B, and node negative where sphincter preservation is possible, where with surgery alone, I can give good functional outcome and good oncological outcomes as well. Now, when I execute intentional wait and watch for this group of patients, the patients need to know that if they fail, they're going to land up with a dual or maybe triple modality therapy to get an oncological outcome that I can do with surgery alone. But then the radiation oncologist will argue, it's about avoiding the surgery. That's the entire point of the whole debate. We have to get the organ, prevent the organ from getting operated. And why is that? Because TME causes low anterior resection syndrome in nearly everybody. How many? 80, 90%. Major LARs in 62%. That's from the rollout trial. But do they tell you that neoadjuvant radiation itself is an independent factor to predict major LARS. They may have not told you that. So it falls to me to do that. Anyway, if we look at the Dutch consortium, if they looked at these wait and watch patients, no surgery, just radiation. Major LARS 25%, only because of radiation. And the major LARS does not decrease with time. It remained almost constant. Add to that the erectile dysfunction, nearly the same that we see after surgery, 20 to 30%. If you look at LARS after a TME surgery, it improves after time, actually. It's a small Chinese study, and they said 44% at about 2 years, came down to half of that at 3 years. And in this study, only 19% have got radiation. So if you leave a remnant rectum that is normal, it heals, and your functional outcome improves with time. If you radiate the rectum, it is radiated for life. Another study from the FOVAC study, it looked at the LARS in the FOVAC group. They had 61% with major LARS. 49 of those 61, 59% were in the chemo-RT arm, just 12 in the chemotherapy arm. So the question is, what is causing the LARS? Is it the surgery or the RT? So I leave you to answer that one. LARS in the Indian setting maybe is not such a big problem. We looked at our own data and saw the incidence of major LARS in long course and short course radiation. What I want to point out here, we found incidence of major LARS was just 6.5 and 8%, not like the 62% in the ROLAR trial. Maybe we have younger patients, better sphincter control, different diet, and maybe our patients just cope better. So there has been a trial, as we've seen in the previous debate, to avoid radiation. This is the PROSPECT trial. And I'm not going into the details of this. I just want to point out one point that was missed in the debate. PATCR was 22% with only chemo and 24% with CTRT, nearly the same. Okay, so if we go and look at the second study from UK, it shows that patients who get radiation and surgery as compared with surgery alone do very poorly regarding bowel control, urinary and sexual dysfunction. 2 minutes more. The problem is when we have a permanent stoma, yeah? So watch and wait avoids permanent stoma. Here I accept defeat. Yeah, if the indications for APR here are if you don't have a distal margin, even if you have a small tumor, if you can save the rectum, go ahead, patient benefits. If the external sphincter is involved, we can save the rectum, go ahead. But beware, if you have a T4B lesion, you're less likely to get a complete response. And if you have an incompetent sphincter complex, I mean, these patients probably require an APR anyways. If you look at results from the International Watch and Wait database, I just want to point out the local regrowth rate was 25%. This is 47 institutes from 15 countries. They 10% distant metastasis. And if you have a local regrowth, then you are marked for distant metastasis because that is an independent factor to predict distant metastasis. And patients need to know this when they decide for wait and watch. Another issue is how long to wait. Let me pass my rebuttal. I just want to finish this. Yeah, so how long to wait? So there's often a discussion. You look at Habergama's paper. They says we get responses up to 26 weeks. I know, but there is a protocol for waiting. And even after waiting, the max is about 6 months. I mean, we cannot observe a patient on near complete response lifelong. So at some point, surgery has to come in. Can you really keep up with the follow-up schedule? Look at it side by side. Once a year scan with bloods every 3 months, scans and scopy every 3 months. And that's if you have a CCR. If you have an NCR, get ready to get scanned and scoped every 6 to 8 weeks. Do you really have the expertise? Yeah, so you need to be really skilled at finding out the complete response and the early regrowth. Even today, I will do a PR and say this is definitely growth. And Reena madam will come in and say, no, it's just a thick scar. And then the fight starts. So there is disagreement even between experts. And in the OPERA trial, that's how they defined it. It was extremely well laid out to actually define what are these things, because there is still a lot of confusion. So the radiation oncologist and the surgeons are fighting, and the med-onc comes and says, well, you all can go home because one injection and I'm getting 100% CCR. So that's fine, but that only works in deficient MMR. And Dr. Vikas Oswal showed us that in TART-TMH, that applies to 1% patients. 1% patients. So if you look at our clinical response, we have 95% confidence intervals. We ignore the 2.5% on the other side. How do you feel about the 1%?
Sir, it's time's up, sir.
Yeah, just one. To summarize, that's what I have spoken. So I just want to say, when we counsel patients for wait and watch, don't counsel like a radiation oncologist. Don't counsel like a surgeon either. Put both the arguments for the patient, and if they say no, then it's no. Thank you.
Thank you, sir. I would call next speaker, Dr. Reena Engineer, ma'am, to do the rebuttal. S. Thank you.
Thank you so much. It's my pleasure to speak on watch and wait, and it's a real topic close to our heart. And like in TMH, yes, as Ashwin said, we end up in argument, but yes, we are learning as a group. And we know that, this has been discussed with, and then Dr. Habergama. So I would tell, if there is any surgeon in the crowd, that you get more famous by not operating than operating, because she's the queen and the goddess of watch and wait nowadays, where she's a surgeon who decided not to operate on the patients when they have complete or near complete response with excellent outcomes. So there is no level 1 evidence, and there will never be, because many RCTs, one was also designed by Dr. Habergama herself. And when you tell the patients you have complete response, but I'm still going to do APR or any surgery, no patient is willing to give the consent. So there will never be a randomized head-on-head comparison between watch and wait versus surgery. And so we have to rely on retrospective analysis, systematic reviews, and meta-analysis. So this was published in 2016, and then they showed that organ preservation rate was 62%. It was most of the regrowths were surgically salvaged. It had good overall and disease-free survival. And the initial studies, of course, didn't have quality of life in there. So in this series by Renehan, this is the Dutch group. They compared the surgical patients. They match pair with the patients who went for watch and wait. And they said, compared to surgical, watch and wait is a very safe, where disease-free survival, overall survival, and better colostomy-free survival. There have been other systematic reviews, again speaking the same thing as local regrowth rate. Most are salvageable. There are no differences in outcome in whereas survival, disease-free survival, or overall survival. This is international wait and watch database. Again, that they also said the same thing. It is at the median follow-up of 3 years. Now they have more than 1,500 patients on their database, and the outcomes remain to be good. And so surgery versus wait and watch, there's another recent meta-analysis published in 2021, and they said that the local regrowth obviously was higher in the watch and wait database, but majority again were salvageable. The distant metastasis and cancer-related death was the same. So again, it was oncologically safe. So now, does delayed TME surgery in a watch and wait strategy after an SCT-RT leads to additional hospital costs or surgical morbidity is the question, as discussed already by Ashwin. And this study actually looked at the delayed TME surgery versus wait and watch strategy when they had to undergo surgery. So again, the outcomes, readmission, surgical outcomes, nothing was different. So again, the overall survival. So again, there was these patients did not have any inferior outcomes. So these are the changing concept of survival and function, and we have to take our time to decide. Surgeons always argue that how do you know this is the tumor is gone? We rely on MRI and the Scopy findings, and this is a learning curve for the entire MDT. It cannot be done by individual alone. And now we have, with the TNT coming, there are two approaches, whether to escalate with chemotherapy in the TNT format or to add on to brachytherapy. chemotherapy. So in the OPERA trial, the organ preservation rate has been reported 54%, and then now it is with the brachytherapy, it has gone above 80%. So what is good? We have to choose, like now we have 3 brachytherapy related study where organ preservation rate ranges from 60 to 80%. So more and more radiation dose safely can be delivered, and so we started doing, because when we started, we were really scared that what will be the compliance rate, will it be acceptable to our patients. For the first 36 patients, we were very comfortable as a group, and we also observed that a third of the patient continue to respond beyond 12 weeks. So we can wait, we have to operate if there is tumor, or if there is tumor, it will show up. So that's the argument all about, that how long should we wait? There is no definite conclusion, but yes, if the tumor is continuing to respond radiologically, endoscopically, or PR-wise, there is no need to operate. We have to keep on waiting on them, and yes, we do brachytherapy to enhance the tumor response at our center, MR-guided brachytherapy. In our first series of 145 patients, which is under publication, like the NCR patients were near complete response, were the very confusing patients, and somehow the surgeons decided to go ahead and operate on them, and 85% had PAT-CR. So it was a learning curve for us. So eventually only 38% achieved organ preservation at the median follow-up of 2.5 years. And the outcomes were excellent in our own hands, and we got more confident. We did this prospective study of 68 patients. Again, this is under I'll be presenting in ESTRO 2024. This is unpublished. And currently, our organ preservation rate for these select group of patients where we give neoadjuvant chemoradiation followed by brachytherapy, it is somewhere around 60 to 64%. And PAT-CR rate continues to be 23%. So again, as Ashwin has raised the concern that complete clinical responders are good, but what about the NCR patients? So the first alarming study had come from MSKCC, where they published that when these NCR patients are the ones who are throwing distant mets, and we have to be really careful, 36% also had local regrowth. So the regrowth patient, the NCR patients are the ones which can be game spoiler, or which can lead to the poorer outcomes. But then when we went through the paper, we realized there were many problems with the MSKCC patients. They were not diagnosed with they did not have MRI at every follow-up or the baseline, and the organ preservation, the rectal preservation of the group was 79%, but there were a higher local regrowth rate, and which led to higher distant metastasis. Now, in the IWWD, similar outcomes were seen, that when the patient have clinical complete response, it is only less than 5%, the distant metastasis. But when they have near complete response, it is 17.8%. And again, in this was again studied by the group, American group. Again, they also saw that NCR group had a higher distant metastasis rate. But this argument has been now published by the OPERA group in the JAMA 2023, where they compared that the CCR group, again, the distant metastasis rate is 5.2%, and the NCR rate is 13%. So now, are we doing any harm in the NCR patients, which are also the third of patients? So if we compare with the surgical series who had complete pathological complete response, so these are the huge big study and mass, there's a meta-analysis, over 3,000 patients, and we see the patients who have PCR and who undergo surgery, the distant metastasis rate is 9-10%, or in the complete clinical responders. So again, it is not inferior, I would say, even in the NCR patients, and more than 50% of the NCR patients again have organ preservation. And even in the younger group, it is not harmful, or it does not decrease the quality of life. And it is for the select group of patients, and surgical salvage is always there. Quality of life definitely matters, and compared with the surgical series, they showed that the patients who have wait and watch, they are under watch and wait strategy, they have a better quality of life, they have reduced fecal incontinence, and the satisfaction is also better. Cost effectiveness also is an issue, and there have been many publications where cost effectiveness is definitely a third. It is reduced by third. Even at our center, it is so it is a MDT approach, and or it is a patient's perspective has to be kept in mind. He has to be told with all these pros and cons. And this is a very interesting book written by us cancer patient survivors. So we as oncologists, we sometimes override, and we are so bothered about this quality. This outcome, distant metastasis rate, and but we have to listen to these patients. Even the ESMO guidelines, it's a viable option. NCCN guidelines, it is a viable option, and we have to explain to the patient, and we have to see what the patient prefers. So now the chances of organ preservation are more than 50%, but when we have dose escalation strategies, now it has gone to 75%, and in the larger tumor, it is more than 60%. So should we be denying the organ preservation to these patients, and when it is feasible, and when we can have a better quality of life, and it is cost effective? And so I would say the only contraindication to watch and wait is if the patient desires, in spite of having complete response, he desires for a surgery. That is the only contraindication for watch and wait, and it can be practiced outside clinical, provided you have a good MRI, you have a good radiologist, good endoscopist, MDT, database, and follow-up coordinator. Thank you so much.
Thank you, ma'am. I would request Dr. Bhushan Zadek to do expert comments. I think that Ashish wants a question. Amula.
Always learn a lot when you speak, ma'am. I just wanted to ask you, when we do TNT, there are various ways you can do TNT. So as a radiation oncologist, do you really think that it's important to start radiotherapy as early as we can? And then maybe whatever intensification with chemo we can do it later? Does that result in higher organ preservation, or actually it doesn't matter? As long as you wait long enough, you would get the CR anyway.
No, now there is level 1 evidence by this OPRA trial. It's a phase 2 trial, but again, it showed that we start with chemoradiation. It is like, of course, chemotherapy also adds, but the radiation, the tumor, the apoptosis time, it gets tumor to shrink more and more. The more, it is a time-based approach. So definitely chemoradiation should be started. Whether short course or long course is investigational.
Because the reason why I ask this, because as medical oncologists, we always wonder how much of systemic therapy the patient should receive. Some of them are node negative, some of them are node positive, some of them, and also always difficult for us to deliver post, especially long course chemoradiation. So I mean, if you really think the sequence is important, or can we play around with the sequence?
So I would go like that. If the patient is a probable case for watch and wait, when the tumor is less than 7 centimeter or 8 centimeter, it is non-circumferential, it is more moderately or well differentiated, no signatoring, no mucinous, no high-risk factors, no EMVI, no lateral nodes. So all these cases are probable cases of watch and wait. We can start with chemoradiation. But if they have very high-risk features, I think we can always start with chemotherapy also in such cases.
I have one question, madam. Thanks for the excellent talk. Actually, this wait and watch should be labeled as rigorous wait and constant watch, because the follow-up schedule is very rigorous. You have to have scopies and parietal examination, MRIs. So what do you think in the real world outside tertiary care centers like Tata, but in the real world practice in India, this will be feasible?
So it's a learning curve, and it is very much dependent on how you explain to the patient. Of course, we have a dedicated nurse calling them up and reminding them of their follow-ups. In spite of that, there will be a 10% breakdown. So before we started doing this watch and wait, when the patients were designated for likely APR, there would be a 40% dropout rate. They would sit at home anyway. They would not come for surgery. But now it has dropped down to less than 10%, which is, we are very happy, because it's a very patient-driven approach. You would be surprised that we get patients from, a farmer from Bihar, and they also are willing to come if they can avoid surgery. So this is a very, very patient-driven approach, and they should be given an opportunity and discuss with them.
So for highly motivated patient, probably.
Yes, but I'm surprised that even the most illiterate people are also highly motivated. Socio-economic status has nothing to do with this.
Fine.
Thank you. Any more questions? I will call expert over Bhushan. Dr. Bhushan, I think I will ask Atul sir only to give some expert comments, sir. Dr. Atul sir, you can. Okay. Sir is not. Sorry. I'm not asking for rebuttal because I think they overshooted the times, but expert comments.
So again, the same thing probably if we are choosing our patient rightly, probably all the options are available. So again, the idea is not to run down one specialty or this thing, but of course, I think the trial have shown that there are the few patients who can be spared the surgery. And of course, otherwise, as the oncologist, I'll say all the three specialties are equally important and better that we exist in a cordial manner and this thing. So we probably work. So clinical trial is a different situation. Real world practice is altogether different situation. And we often discuss when I used to be at AIMS and now also, there are a lot of DMJ discussion going on, surgeries mein kare, nahi kare, radiation dena, nahi dena. Similar to that, probably we always discuss whether we follow the procedure for the chemo trial or we go for the other trial, this thing. So we prefer personally, if the performance status is good, I personally prefer to start with the chemotherapy and if possible 3-drug combination. Particularly for the high-risk patients who have the fixed tumors and this thing, at least you get better response and this thing. But that's it, probably all three are probably here to stay.
Thank you, sir. I think I would call next speakers. So the theme of the debate is skipping one modality or looking at as an option. So I would call Dr. Viraj to talk about navigating post-operative choices, neoadjuvant chemotherapy in 60-year-old male with high-risk stage 2 colon cancer. It's not a case presentation, it's just a topic. And negative circulating tumor DNA at 4 weeks post-surgery.
Thank you, organizers. For the next 10 minutes, I'm going to convince you that if you have this patient walking into your office with negative ctDNA at 4 weeks, it's a blood test, then you're not supposed to give adjuvant chemotherapy. And I'll tell you why. That's in the discussion point. So let's come to NCCN, which everybody starts their debate with NCCN. So NCCN is completely clueless when it comes to stage 2 colon cancer. Look at this. When you have low risk, you can do observation, you can do 5FU. When you have high risk, you can do 6 months of full fox, you can do capecitabine, and you can also do observation. None of them categorized. That means everything is category 2A. This is clearly highly confused NCCN. I've never seen NCCN be so confused. And the reason is this. If you see the largest meta-analysis for stage 2 colon cancer, this was published 10 years back now. The 5-year DFS, if you do not give chemotherapy to stage 2 colon cancer, is 79%. And if you do chemotherapy, it is 81%. So 2% absolute advantage of doing adjuvant chemotherapy in stage 2 colon cancer, whatever chemo you choose. And we know 2%, it's substandard to say at best. And if you see, what about oxaliplatin? How about we use FOLFOX? If we see the mosaic, again the registry trial, whether it is low risk, whether it is high risk, you can't put a laser between the two Kaplan-Meier curves, further suggesting that adding oxaliplatin in stage 2, even in high risk, does not make any difference. This is the 10-year overall survival. And again, what does NCCN do? Again, confuses us. A survival benefit has not been demonstrated for the addition of oxaliplatin to 5FU. So it concedes that oxaliplatin should not be used. And then it says FOLFOX is a reasonable option for stage 2 with multiple high-risk factors. So clearly, this is an area where we need to use our brains because we owe it to our patients. And what is the high risk? We've been taught this for last 15 years. The T stage, the grade, LVI, PNI, obstruction, having less than 12 nodes resected, MMR status. Mind you, the hazard ratio for risk of recurrence for all of these, the highest is 2, hazard ratio of 2. Let me show you the risk factor with hazard ratio of 13 and 18. What is this? It's a new kid on the block called liquid biopsy or called ctDNA at 4 to 6 weeks after operation. If it is positive, whatever stage it is, 1, 2, 3, 4, doesn't matter. The risk of recurrence hazard ratio is 18, 13, and these are all cohorts of studies. One of the first studies was this, Professor Ginny Tai from Australia. She showed almost 8 years ago that in stage 4 colon cancer, where surgeon has operated liver cancer, liver disease, the purple curve is those who have a blood test liquid biopsy positive, 0 survival at 3 years, while if it is negative, 85% survival. Doesn't matter it is left-sided, right-sided, KRAS positive, BRAF positive, absolutely no difference. A blood test positive, you're not surviving. A blood test negative, you are surviving, at least for 85%. So it's a strongest prognostic marker, and since then we have 5 prospective, some randomized studies or some observational data sets that have been presented in last couple of years, and I'm just gonna bore you with 2. The most important is the dynamic study. It's almost 2 years now. This was published in New England Journal of Medicine, again from Australia, Professor Ginny Tai's group, where they did 450 patients of stage 2 colon cancer. 150 of them would be decided as per the treating physician, and 300 of them would be decided based on a blood test. If a ctDNA is positive, you treat them. If it is negative, you leave them alone. And you wanted to see, by doing this, do you decrease survival? Are you harming your patient by not giving chemotherapy, which you would otherwise think you are giving? And the second endpoint is, by doing this, are you reducing the number of people who are subjected to chemotherapy, right? So the short answer, no. Both curves on top of each other, 92% whether you use your brain and 92% if you use a blood test. So you are not harming your patient when you use a blood test at 4 weeks. Importantly, I want to draw your attention to this. 50% of patients whom we call today high-risk stage 2 were not given chemotherapy, even if the physician, even when it was on standard of care. That means the Australians are far more smarter than what we are doing. Can you raise your hand if you have a T4N0 who would not give chemotherapy? Any hand? I'm sure there's no hand. T4N0, I would not subject them to observation. Well, here almost 40% they did not, so congratulations to them. Even then, the people who got chemotherapy was half. So 15% if you use a blood test, and 30% if you use your discretion. So by halving the number of patients who go on chemotherapy, you still get the same survival. I think you don't need anything more than to convince me that definitely I should be using this blood test. From US, again, earlier couple of months back, there was a similar study being presented by Dr. Pashtun Kazi. Here 600 patients were shown. Stage 2, stage 3 does not matter. If you are blood test negative at 4 weeks, you are on the blue curve. The 2 years DFS 92%. Stage 2, stage 3 does not matter. And if you are blood test positive at 4 weeks, does not matter, stage 2, stage 3, your survival is only 30% at 2 years. You see the marked difference? It's unbelievable. And further, he comes and shows that all the patients who got chemotherapy, and if they had MRD negativity, the graph on the right shows you that chemotherapy was not doing anything to these patients. So if your MRD was negative, chemotherapy didn't add anything. Although we have to give chemo currently, according to the guidelines in stage 3, but this study, contradicts or tells us that probably what we're doing was wrong. And the chemotherapy only helps in patients who are MRD positivity. So my opponent is going to show you only NCCN, because I think so he only has NCCN to show. 1 minute, sir. 1 minute. I'm going to, and he's going to show you this, because he has nothing else to show. He will show you this. The panel believes that there are insufficient data to recommend the use of multi-gene assays, blah, 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 to estimate risk of recurrence or determine adjuvant therapy. Now, I'll tell you why this is problematic. I think so this is a typo. This has not been updated, and I'll tell you why. Because the next statement is a lie. ESMO has released a similar recommendations regarding these assays, stating that role in predicting chemotherapy benefit is uncertain. Now, ESMO has not updated their guidelines for last 3 years. The last ESMO guidelines for early stage colon cancer is in 2020, and there was no liquid biopsy back then. So I went there to the 360 button, and there is nothing of this mentioned. So I think so, leave a couple of years more, and this paragraph would be changed. I thought he's going to come with second argument, so I'll just take 1 minute. About COBRA. COBRA was presented this year, again, GI ASCO, and all the enthusiasm went down. It was on low risk stage 2 colon cancer. And long story short, the chance that you would get a blood test positive is just 2.5%. It is too low an incidence for you to measure in 700 patients. So only 700 patients they could gather. Actually, this requires 5,000 patients. Although it was a positive study on numbers, but the p-value fell short because of the statistics. Whether you like it or not, the global market of MRD is going to be huge. Again, I'm not pitching for any company here. This is just a global MRD. There are at least 20 players in this, whether we like it or not. So to conclude, ctDNA is the most powerful prognostic marker for recurrence in colorectal cancer ever that we have seen. We can't throw every resected colon cancer patient under the chemotherapy bus. If you don't know anything, just give them K-pox. I think so many of us do here. ctDNA approach to select patient for adjuvant chemotherapy appears very promising. I have started doing that in my practice. The only problem with the current technology that we have, and I see some industry people here as well, there is a tremendous opportunity to develop MRD-based assays because still we miss those peritoneal and lung metastases. And the day we conquer that, I think so this test, hands down, would be the best test to use. Thank you so much.
Thank you, Viraj. I think I would not invite Sachin. He's already on the stage. So for the rebuttal, I need to think, I hand over Sachin.
Thank you, Viraj, for all those wonderful efforts to convince the audience that this is some magical test and should be used. And to replace our brains, this is a magical test. I think the efforts were quite genuine. But when we are in 24 today, and I'll categorically say about ctDNA negative, I think, and you have rightly avoided the statements in NCCN that it is not recommended. So I think you have already made me win this particular debate by accepting that this is not a standard of care today. But that actually I'll save my time from other slides and come back to those 2 studies which you were trying to convince that they are the ones which will help us for you using this test as a more accurate prognostic marker. So I'll not go in details. We know that high risk stage 2 colon cancers do have a risk of recurrence. And when you have 2 or more risk factors, the risk of recurrence is almost 25%. Our patient, mind you, had 2 risk factors. So our patient has, even though ctDNA was negative, clinically definitely carries a very high risk of recurrence. And we all know that adjuvant chemotherapy has a benefit, even though the magnitude of benefit may be low, but it has a survival benefit. So basically, our question is, when we are talking about high-risk stage 2 colon cancer, is ctDNA a reliable biomarker to identify patients who are really at high risk and to focus chemotherapy only on those patients, or to identify very low-risk patients where we can avoid chemotherapy? So this is what the question is. And the answer is obviously no. The reason is the level of evidence for these particular tests so far is absolutely not enough. Most important three limitations of all the clinical validity studies so far. Most of the studies are retrospective or at the most prospective observational studies. None of the studies have actually been taken as interventional studies. I'll come to the dynamic study. Secondly, the size of most of the trials has been very low. The sample size, the number of population, you were mentioning, to prove something you need thousands of patients, and now we are talking about the data which has only hundreds of patients. And that too, whatever studies have been included, there has been a lot of heterogeneity. They have included stage 2 and stage 3 together. They have included ctDNA positive, ctDNA negative, and most importantly, the decision for adjuvant chemotherapy was left to the physicians. So that has added to a lot of heterogeneity, and we cannot come to a conclusion from this small number of patients that whether that particular test is really useful to avoid chemotherapy. And one more important limitation is the duration of follow-up is really short. We know that the recurrences can be there even during the late phases. So these are the few tests. I want you to concentrate on number of patients. The number of patients are hundreds, less than 250, less than 300. Only one trial had almost 1,000 patients, but that was all for stage 3. So can we really come to any conclusion from these small numbers about a decision of adjuvant chemotherapy or not giving adjuvant therapy in stage 2 high-risk patients? I think the numbers are too less. Secondly, there is a variability of ctDNA positivity from 10% to even 30% or 40%. Now I'll come to the 3 prospective studies which Viraj has tried to convince us from. This was the bespoke study which was presented in this particular ASCO GU 24. The conclusion was it's a very highly prognostic marker, and if you have ctDNA negative, you can skip chemotherapy. Look at the numbers. The data was presented for 350 patients. This is an early trial discussion. 154 patients were stage 2, and out of that only 130 patients were ctDNA tested. So on a data of 130 patients, are we justified to come to any conclusion? And then one important thing is, all these were purely observational. That means whether the patients were received chemotherapy or did not receive chemotherapy, there was an intrinsic bias in these particular interventions. The Galaxy study or the Japanese study, which he has not mentioned, this was patients, so particularly this was around 530 women, pathologically high risk stage 2 and stage 3 patients, and ctDNA negative. So this is what we are looking at. So ctDNA negative at 4 weeks, they were observed, and it was concluded that even if you give or you don't give chemotherapy, the outcomes are not different. That means ctDNA negativity, you can avoid chemotherapy. This was the conclusion. But then again, the numbers are pretty small. Only 291 patients of stage 2, follow-up of only 97. And although it may not be statistically significant, numerically, those patients who received adjuvant chemotherapy, the DFS at 18 months was more by 3%, 94% versus 91%. And now the most important trial, I want everyone to focus on this particular trial. What Viraj has skipped is obviously for the purpose of debate. I am sure he has gone through the trial in details, but for the purpose of debate, he has definitely not conveyed few aspects. So phase 2, although it's a randomized control trial, 2:1 randomization, where patients were treated on the standard clinical parameters or versus CT-guided TNA. The endpoint was RFS at 2 years. The trial concluded that even if when your decisions are based on ctDNA, you do not harm the patients, the survival is same, and you may save chemotherapy in almost 50% of patients. This was the conclusion. But as actually Viraj was trying to praise the Australian doctors, I would say the standard arm was highly untreated. There was suboptimal treatment in the standard arm. only 40% of patients or 48% of patients, in spite of being high risk, they were not given chemotherapy. So this is an absolute suboptimal treatment for a standard patient, high-risk patients. And if they would have received chemotherapy, possibly the difference would have been seen. You cannot conclude that this is a non-inferiority trial. The trial was concluded as a non-inferiority trial. But if they would have received the standard of treatment as what we follow, possibly the outcome benefit would have been seen, which was not studied at all. So this is one important study. This is a exploratory analysis of this particular trial. Those patients who were ctDNA negative and did not receive chemotherapy, just look at the figures. 3-year RFS for those patients who had low risk, fine, it's all fine, 96.7. But if you have high risk and ctDNA negative, the risk of recurrence is 3 times more. It is 86%. So ctDNA negativity does not give you any assurance that the risk of recurrence will be low. If clinically high risk, that still stands a very important parameter, irrespective of ctDNA. ctDNA was negative, still there was a recurrence in almost 15% of patients. These are all stage 2 patients, stage 2 high risk. So even the authors have concluded in this particular trial, you may not give adjuvant chemotherapy if ctDNA negative, but clinically low risk. If they are clinically low risk and ctDNA negative, you may not give chemotherapy. But ctDNA negative and high risk, they do need chemotherapy because the risk of recurrence is definitely high. So what we can conclude from whatever clinical validation data we have, if there is a positive ctDNA, there is a high risk of recurrence, yes. If there is positive ctDNA, there is likely benefit of chemotherapy, definitely yes. But if ctDNA is negative, can we say that ctDNA supersedes your conventional clinical markers as predictive marker and de-escalate adjuvant chemotherapy? My answer, and I would sure everyone in the audience will agree, the evidence is not there. Ideal trial, what we would have wanted is high-risk patients, ctDNA negative, you treat them or randomize them to observe or adjuvant chemotherapy. I am happy that some studies are coming up. There are studies, this is the NHS study which is still enrolling, so no results are available. This is about the clinical validation. Now we'll come to the lab validation issues. Which test is best? Ideally we know that ctDNA needs to be a very highly sensitive as well as specific test. Now there are many aspects which are not clear. There are definite centrifugation protocols. If your centrifugation goes haywire, your ctDNA or cell-free DNA interpretations are going to go wrong. Which is better? Whether it's a tumor-informed, I'm sure you must be knowing, tumor-informed means you do that NGS testing in the tumor first, and then only those genes are tested in the blood. So whether the tumor-informed is better or directly plasma tests are better. We don't have any answer to this. When do we really collect the blood sample? At 4 weeks, at 8 weeks, we are not sure. And as he has rightly mentioned, if there is a peritoneal disease, the sensitivity of ctDNA is low. So we'll have to keep that in mind as well. This is my slide. This would have seen. So what it mentions in the red circle is, what it mentions is, if you have ctDNA negative, we should not de-escalate chemotherapy. Very categorically mentioned, no confusion here at all. This is only one sentence in the particular slide where NCCN is very, very, very clear. No de-escalation, right? COBRA study you have already mentioned, there's a lot of confusion about the ctDNA. In spite of giving chemotherapy, the ctDNA did not clear. So we really don't know what ctDNA is pointing at, whether it's a marker of disease biology or lack of sensitivity to chemotherapy. There's a lot of confusion. So as of 24, not sitting in a umbrella of an academic institute, I don't dare not to offer chemotherapy at this point of time. And my important question to you all, is Capox or Folfox a really toxic regime? Is it like ifosfamide for soft tissue sarcomas? Is it like sunitinib for adjuvant RCC? No, not at all. We have been very comfortably able to give these particular regimes. So denying a safe treatment option and denying an opportunity of cure, I won't agree that no chemotherapy for, even if there's ctDNA negative. And high cost. In India, the cost of giving 4 cycles of Capox is far less than any ctDNA test, even the CTC test. Absolutely fascinating. powerful tool, very magical, but not for today. And one important, this is maybe out of the debate, actually, unfortunately, we have been missing or we fail to remember, we fail to give enough cognizance to simple markers. This is CDX2. This paper was published in NEJM 2016. If CDX2 is negative in stage 2 cancer, and if you don't give chemotherapy, the risk of recurrence is increased by 40%. So instead of doing ctDNA, I would insist everyone to do a simple CDX2, although it's not included in the trials. So ideally, the debate should have been CDX2 positive as well. Thank you.
Thank you, sir. I think Dr. Ghanashyam, sir, for expert. I think Vikas wants to ask a question. Go ahead.
Yeah.
Ghanashyam, sir, you can come stage. No,
I'm a patient with stage 2 colon cancer, high risk. I have, I come to your clinic, I say my ctDNA is negative, but you say 5 to 7 or 10% are positive, and it's negative for me. How long I should keep doing it? And one point where those who had ctDNA negative in the beginning and had relapse, they had a worse survival. So I should keep doing it for 3 years, 5 years, how long? I'm a fan of ctDNA, but I'm confused.
So 2 points you asked. One is how long do you do? So typically current recommendation or practice is for 2 years. You do surveillance for 2 years, once every 3 months initially, and then as 1 year is done, you do at 6 months. Point number one. Point number two, completely the contrary to what you said. There is a 10% false negative rate. That means if your ctDNA is negative, there is still 10% chance that you will relapse. But the beautiful thing is, in the Dynamic 2 study they showed that patients who relapse despite a negative, they are almost always lung-only Mets who have very good prognosis, vis-a-vis patients who relapse if they have ctDNA positive, they're all liver metastasis disease. I didn't have time to show that slide.
Will I wait for lung or liver met versus take CAPE single agent and sort it out?
The point is, very nice point he made, that there is a high risk of recurrence, but by doing something is not going to change that fate. The day we understand that, we will stop prescribing unnecessary chemo. Because we clearly showed that I agree that you are fearful and I understand that, but doing something won't make any difference.
Thanks, Viraj.
I just wanted to have a comment, especially to what Viraj spoke. He said two things, and obviously as shown in his slides that this is a prognostic marker. It is not yet predictive, and that's what Vikas also said. We don't know if the ctDNA comes positive. We have to treat it like an adjuvant or metastatic. You want to avoid capox, and if ctDNA is positive, you'll probably end up giving capox plus cetuximab or bevacizumab, everything all together. So that is one thing. And second thing, he very nicely said that there is only 2% difference in the DFS and the stage 2 colon cancer. Please, 2% difference. You ask the breast oncologist, they will die. The CDK inhibitors in adjuvant setting, approvals are given, withdrawn on 2%. 2% is a valuable number for a curable malignancy.
We need to be better then. I think so. We need to raise our standards if we are happy with 2%.
In a curative setting, of course it is important. Thank you.
So just one small query is that the fight is going on for de-escalation of the therapy. What about escalation? Stage 2, low risk, ctDNA positive. What do we do there?
So we are not there yet.
I think it's a debate. We are not there yet. It's a debate, and the academic merits of a debate is totally taken in a pinch of salt.
So Viraj and Sachin are good friends. So Viraj is basically a GI medical oncologist till 2 months back. And Sachin is a community medical oncologist who treats from head to toe. So I think both of them have done a great job. So now, if you have a stage 2 colon cancer adequately staged up, so you look at clinical factors. So everybody must do an MSI. So 4-5% will turn out to be MSI high. And third thing, so after 14th March, what Amol has posted in the group of cell-free DNA in cancer colorectal screening of 8,000 patients and early diagnosis and advanced colorectal cancers with a sensitivity of 83%, 90% of specificity. So ctDNA becomes definitely a good tool which is just knocking at the door at this moment. So, as Sachin said, so Folpox, K-pox, or even capecitabine, for 80% of the patients are not toxic like an anthracycline or IPOS or even taxanes. But, so 3 factors. So high risk of recurrence, low risk of chemotoxicity, and third is effective regimen. So if these 3 are put together, so you will always have a patient who is not fit for a chemotherapy post-surgery for XYZ reason. Maybe because of comorbidities, post-surgery recovery. So these are patients, even that was a clinically high-risk patient, so you may not offer chemotherapy for this patient. For this 60-year-old patient who has 2 high-risk features, so in spite of having a dynamic study in your favor, but how many of us clinically, as rightly said Sachin, so who are not in the bracketed of an academic institute in a private practice, and when always there is a medical legal hanging on you, or your next door medical oncologist sees and starts on some therapy if this patient recurs back within next few years. So definitely ctDNA is knocking at the doorstep. So that is a good modality for certain patients where you can always avoid if they are negative. But as rightly said, so if it is positive, so how much escalation, so nobody knows. So that will be probably, so another 10 icons will pass out till we don't have an answer. So I think both of them has so there is no complete verdict on this, but definitely for certain patients, so this can be a good tool just to observe this patient. But for dynamic study, so 2 years, 3 years, so as how long you will be doing that for a country when every state or the country is moving into a scheme-based treatment. So where this out-of-pocket test for n number of tests for next few years is much costlier than the therapy you are looking at for 6 months. Thank you so much.
Thank you, sir. Now, going away from debate to topics. So next is a panel on maintenance strategy in metastatic CRCC. I would call moderator Dr. Ankul Bail to raise the session. I would request panelists Dr. Arif Khan, Dr. Bharat, Dr. Shruti, Dr. Mir, Dr. Arjun, Dr. Satvik, and Dr. Amit to be part of the panel.
So we can sit by this order only, otherwise I'll get confused. Arif, so Arif, you can
start from one end so that.
Arif, start from this. Please sit according to this order, ma'am.
I will say one more order. First is Dr. Arif, Dr. Bharat, Dr. Shruti, Dr. Mihir, and Dr. Arjun, Dr. Satvik, and Dr. Amit. I think Ankur needs spectacles, so he's struggling with both of us.
Wonderful. So thank you so much, ICON committee and Dr. Nikhil, Dr. Vamshi, and Dr. Viraj for chairing this session. So the topic of today is maintenance therapy in metastatic colorectal cancer. And I have my teacher, Professor Atul, Dr. Govind Babu, and many senior oncologists, medical oncologists, who have done in their practice in first line, second line, third line, before 2004 or in early 2000, 5-FU leucovorin before capecitabine introduction into practice. So we were doing intermittent chemotherapy, and we were giving some 5-FU leucovorin with a clear-cut goal that a continuum of care in metastatic colorectal cancer should be done with the least toxicity, with a benefit which is PFS, whether it is turning on to an overall survival benefit. But however, in last 2 decades, many things have happened in between. So first line therapy with a maintenance, re-escalation of that therapy, it's not mandatory to go for 12 cycles of Folfox or Folfiri. It's wiser to stop at 6 cycle, 8 cycle, get a best response, which is ETS or depth of response with cetuximab, get the best response, give a break, give a targeted therapy which is either anti-VEGF or anti-EGFR, reintroduce that previous cycle which was Folfox or Folfiri, manage neuropathy, maintain quality of life, then move on to second line therapy. In between, do a local form of therapy, either in the form of resection, SBRT, ablation, cryo, and get a maximum survival which can be as high as 30 to 40% in a metastatic colorectal cancer, and we can achieve a survival of 25 to 30%, a 5-year survival, which was declared initially only 1 to 2 years. So this is a prototype case. Everybody has such kind of cases, and everybody has tasted success, not once, many times. So this is a rectal cancer with bilateral lobar metastasis, and right or left, KRAS wild or not, BRAF mutated or wild type. So this is the point of discussion. But point of discussion in this next 20 minutes will be how to give that continuation of therapy. So this is an ESMO consensus guideline. We have bevacizumab, we have anti-EGFR2, anti-EGFR cetuximab and panitumumab. There is a data of continuing irinotecan therapy post-Folfiri to get and reintroduction of the previous therapy if we have a good PFS of 1.5 to 2 years and there is no remnant neuropathy. We can challenge and re-challenge this Folfox and Folfiri. So Dr. Arif, any other maintenance therapy in your mind other than these 7 options? So 5-FU leucovorin, we don't use it alone. Capecitabine we use in our practice. Capecitabine and panitumumab, capecitabine and bevacizumab, capecitabine and cetuximab. 5-FU leucovorin, cetuximab, 5-FU leucovorin, bevacizumab. There is a data of cetuximab and switching to bevacizumab, single agent irinotecan, and very fancy attempts of even combining gefitinib with cetuximab, not gefitinib with bevacizumab and many other targeted therapy. So Arif followed by further.
So I use in my practice mainly the 3rd and 4th option. I would not prefer the other ones. Irinotecan I have not used in maintenance as such. I stop it at maybe 4 to 6 months and just continue the 5-FU or capecitabine with targeted therapy.
So Dr. Amit, how much induction you practice? I mean, I just want to give this message. It's 24 weeks or 6 months of Folfox or Folfiri is actually required before maintenance. You push for, because I feel in my practice after 8-10 Folfox or 8-10 Folfiri, the quality of life of these patients goes away.
Yeah, I'm happy to push up till 4 months, but after that it becomes very difficult. So if you're tolerating, yes, I'll finish off the whole regime, but after 4 months, I'm pretty confident to hold on to the therapy.
So I have come across many papers who are saying that do not go beyond 6-8 cycle of Folfox and then maintain this therapy and reintroduce this Folfox. So there are surrogate endpoints.
May I say something? Yes, see, the chemotherapy, the primary intention is symptomatic benefit. We are trying to do a cytoreduction. Not surgically, medically, we are trying to reduce. So at the end of 4 months, patient is completely asymptomatic. Yes, choose to stop it. But patient is still having residual symptoms, then I think it should continue till the end of 6.
So, but at 8 or 10 cycle, the chemotherapy related side effects take over.
Somewhere we have to take a balance between the toxicity versus the effect.
So with cetuximab, this ETS, early tumor shrinkage and depth of response, once you achieve this complete, once you achieve a radiological response, a metabolic response on PET scan, then the papers, both in panitumumab paper and cetuximab paper, they have agreed that switch to this maintenance rather than continuing this chemotherapy cycles. So yes, sir.
I just wanted to highlight the same. So personally, I think that if the patient is responding, you do the objective response assessment, he continues to have either the stable disease over 2 scans or this thing, 1 scan stable, next PR. If the toxicity is not there, then I probably would continue. In case you have stable disease, first, second, also stable, there is no more response, then you have a good point that you can consider probably switching to the maintenance. That's what probably I think.
So what you are saying, sir, that
so it's not just the 4 or 6 cycle or 8 cycles. If somebody is responding and tolerating, that better to continue. Somebody has stopped responding, further response is not there, then the probably symptoms are there, toxicity there, then you probably...
I'll come on to these papers, but they have proved that there is no survival benefit by giving 12 cycles of Folfox or 12 cycles of Folfiri. If you stop at 8 cycle, continue the maintenance therapy, the PFS and OS is similar, and it's a non-inferiority attempt.
No, if you see the Optimax and this thing, that's what you are showing in this thing. So that is probably they have planned with, and then they reintroduce.
Yes.
But if you are giving the continuous on the progress maintenance, then they reintroduce. But if the symptoms are under control, toxicity is not there, and the patient is responding, probably ultimately that also depends upon how much the tumor burden one is having.
So this was the first attempt of maintenance therapy. So Optimox 1 and Optimox 2, and this publication came in 2004. So what was an attempt? Either give continuous Folfox or give 4 months of Folfox, give 5-FU-leucovorin in between, and then continue the rest of Folfox. And in Optimox 2, they gave 5-FU-leucovorin in between and then randomized with no 5-FU-leucovorin in between and reintroduction of the same chemotherapy. It resulted in a PFS benefit and the quality of life of these patients were maintained. So this Focus 4N, which RF was saying that it was published in 2021 in JCO, that after induction chemotherapy, 16 weeks of induction chemotherapy, which is, and then followed by capecitabine, it gave a PFS advantage, not an OS advantage. So my question is, 5-FU-leucovorin alone or capecitabine, is there a difference in this if you don't have to continue cetuximab or bevacizumab? Is the same goal can be achieved with capecitabine alone?
If we are able to give the same doses, what trial has used, probably there is no difference. And practically also, I have shifted maintenance to capecitabine if targeted therapies are not being utilized. Personally, I don't, I beg to differ. I don't continue the chemotherapies if symptoms are completely resolved, because I don't want my patient's cancer cell to get exposed to all the agents without any symptoms.
So let's move on. Madam, what is your goal when you're giving anti-VEGF maintenance strategy, and what problems you encounter by giving bevacizumab? What dose of bevacizumab you give in your practice in maintenance? Because there is a disparity, 5 mg, 7.5 mg, and some over-enthusiastic medical oncologists also use 10 mg per kg, quoting some people. So what is the right dose of bevacizumab in maintenance therapy, and what is the goal, PFS, OS, or both?
7.5 mg per kg every 3 weeks.
So 7.5 mg per kg, and what is in our mind that we can just delay? We have a treatment-free interval, a PFS benefit, or an OS benefit in your mind? So I'll come up with the literature.
Ultimate aim is OS benefit, but here in an aggressive cancer like GI cancers, a good PFS benefit or a treatment-free interval is also very well, it makes a difference in improving the quality of the life, because if the patient continuously, and especially jumping from Folfox to Folfiri is not easy, patient has a residual neuropathy as it is. So my aim is definitely to give a treatment-free break. As such, bevacizumab does not cause any issue as far as toxicity is concerned, and I am very well comfortable with 7.5 every 3 weeks.
So Dr. Meher, 7.5 or any particular preference of the dose?
We are giving 7.5 mg, sir.
7.5 mg. And what dose of capecitabine you are using? So because in our Capox regime or in our Folfox regime, the capecitabine dose is 2 gram per meter square.
Yes. We never go for 2 grams per square meter.
I'm talking about maintenance therapy.
Maintenance, you see, when we use Capox, the patient is tolerating, the same capecitabine dose we usually continue. That is what we are doing. We are not changing or increasing or decreasing the dose. Usually when we start Capox, we'll know how the patient is able to tolerate the dose. And your previous slides of the clinical trials where you have cited that there is no OS difference, though we stop. Coming to the question, when in real world scenario, we should see how many patients are going to subsequent lines.
Most of our patients, they finish off the first line. When we put them on maintenance therapy, they don't even turn up for the second line therapy. I feel the attrition is around 50% in an institute. So we should offer what is best upfront. So if the patient can tolerate beyond 4 months, even if they can go up to 6 months, if he's tolerating without toxicity, I think we can complete the cap box and BEV, and with, if you are getting with BEV, and continue BEV and capecitabine.
So if the patient continues on capecitabine and bevacizumab for next 18 months, the amount of hand-foot syndrome this patient will be. Right?
Yes, and one more thing, when on maintenance, the patient is coming regular follow-up, what we are noting is after a few months, he will have toxicity. Then at that point, we are stopping, even if he's on maintenance therapy.
So let me ask, so what dose of capecitabine, Viraj and Professor Atul, you use in maintenance therapy to such patients? This can be a long game.
80% of patients are 2 BD.
2 BD.
80%.
So it means 2 gram per day.
Flat.
Sir? So this was the Cairo trial which said that give 6 cycles of initial Capox randomized to either observation and low dose capecitabine. The low dose capecitabine in this was 1.5 gram per meter square, not 2 gram, and majority of the patient could not even take 1.5 gram per meter square, and it was reintroduction of Capox BEV in both the arms, and they found a PFS benefit, not an OS benefit. But in Cairo 3, those patients who were BRAF mutated and those who were RAS mutated, the quantum of benefit was certainly higher with capecitabine bevacizumab. It is well understood that anti-EGFR therapy will not work. So this is AIO0207, which randomized 3 randomized to 5-FU BEV alone, and a complete pause and reintroduction of. So every time that reintroduction of the previous responding regime is coming. So, and there was a OS benefit and a PFS benefit, but the most important part was the Cairo 3 and AIO207, the quality of life assessment of these patients were maintained, and the quality of life, so no adverse effects were there, and they were able to continue this therapy. However, there were some other papers like PRODEGE, which showed no advantage of PFS in OS when BEV 5-FU or BEV capecitabine was given. There was an attempt with bevacizumab, the triplet used FOLFIRI-NOX, FOLFOXIRI with bevacizumab, and continue maintenance 5-FU BEV. So this was showing both PFS and OS advantage. In first line CRC, if you give a triplet with BEV and continue BEV maintenance, there was an OS advantage as compared to a doublet which was FOLFIRI. This was a pooled analysis. So in pooled analysis of various studies from Cairo to AIO, it clearly said that there is no OS advantage till date of continuing BEV with either 5-FU or capecitabine. However, there is just a PFS advantage till literature. So coming on to our next panelist, coming on to anti-EGFR maintenance therapy, what do you feel that is easier to give? We didn't discuss BEV toxicity, we'll discuss that BEV toxicity. So it's easier to give cetuximab or panitumab in maintenance, or is easier to give bevacizumab maintenance? Because we have a choice now. We have a choice. So which is easier in your practice, cetuximab maintenance or a BEV maintenance?
BEV maintenance is easy compared to CETEX plus panitumab, because we can monitor the hypertension and the other bleeding tendencies easily compared to the CETEX.
So cetuximab rash and cetuximab nail changes and skin changes at time can be a problem when a long-term cetuximab is going on. So question to my next panelist. So again, the same question. We have a PFS advantage, OS advantage, or both in your practice. What is in your mind when you're choosing cetuximab in maintenance therapy?
Definitely PFS, although already discussed that our ultimate goal is OS, but we do see that it is the PFS which we are more worried about in our context. So definitely at least the PFS should be there.
So this is our goal. So I'll come. So I'm just asking, in your practice as a maintenance therapy, which of this therapy is easier? So proteinuria and accelerated hypertension or a hypertension, or we are worried about skin changes, because we see both kind of patients. So I feel that bevacizumab practice is easier. Cetuximab rash and cetuximab nail changes with capecitabine is. Yes, so cetuximab with capecitabine or cetuximab with 5-FU-leucovorin. We have a Panama trial, we have a Ballantino trial. So goal of, yes, Amit.
So, to what Sir said, there's data, you can defend data both ways. There's a lot of data, but in practice, I guess most of my panelists would agree. So, when you look at maintenance, the patient is doing well, and for the maintenance, if you are using capecitabine, mostly is we are dealing with cosmetic effects. So, 5-FU, if my patient is convinced to give 5-FU-leucovorin, I would prefer 5-FU-leucovorin over capecitabine, because capecitabine, the recommended dose, they don't tolerate in my practice, if you ask me, the maximum they tolerate is 3 tablets a day, not more than that. Even bevacizumab versus cetuximab. Now, if you look at the Cairo 3 trial, they say there is a trend towards OS benefit. For EGFR, there is no OS benefit. But when we talk about CRC, in convention, we know there's no OS benefit. We don't use it really. But in CRC, we have just 2 mainline chemotherapies. So if I'm getting a good PFS, I'll jump onto the drug. So coming to BEV versus EGFR, I'm always happy with BEV because cosmetic is the main issue rather than any other thing.
Absolutely. So capecitabine and cetuximab is a difficult regime to maintain rather than capecitabine and a BEV regimen. So this is we're going to discuss anti-EGFR trial. So macro-2 support continuing EGFR. So it was 8 cycles of FOLFOX cetuximab and continuing cetuximab rather than 12 cycles of cetuximab FOLFOX and then continuing cetuximab. So it was a non-inferiority. So 8 cycles of FOLFOX cetuximab getting an ETS and a deep response, and then switching to cetuximab is non-inferior to 12 cycles of FOLFOX cetuximab. So this was COIN-B study, which there were 2 arms, 64 patients each, FOLFOX cetuximab, 12 weeks, give a complete break. Then introduce FOLFOX cetuximab after a break of 2 to 3 months rather than giving cetuximab in between. So FOLFOX cetuximab complete break, FOLFOX cetuximab and cetuximab as maintenance. So it showed that no significant benefit with either of this regime, but the quality of life of the patient who got an intermittent FOLFOX cetuximab was slightly better rather than continuation of cetuximab and FOLFOX. So this was phase 3 ERMIS study which said that FOLFIRI up to 8 cycles with cetuximab and FOLFIRI up to 12 cycles with cetuximab and cetuximab maintenance. It said that those patients who got a good ETS, early treatment response with cetuximab, their OS and their PFS was better. However, those patients who did not show that early radiological response, their OS and PFS was not better. So this is PRODESH 28, which said that there was both OS maintenance and a PFS maintenance when cetuximab and cetuximab maintenance alone was given to these patients. So there's a data towards other anti-EGFR, which is a Valentino study and a Panama trial. So Valentino said that continue panitumumab with 5-FU-leucovorin, and Panama said that continue 5-FU and panitumumab as a maintenance therapy, which can give you a PFS advantage. However, there's a multivariate pool analysis which also suggests that there's only PFS advantage with adding on cetuximab as a maintenance, not as an OS. This is another systemic review and Bayesian network meta-analysis of all the studies of cetuximab, which said that if you have got a left-sided tumor, metastatic left-sided tumor, which is KRAS and RAS wild type, you can omit capecitabine and go on a single agent capecitabine that will give you a same PFS advantage. So we require to maintain our quality of life when we are giving either BEV or cetuximab maintenance. So we have discussed that there's a triplet trial as well, FOLFOXIRI with BEV and FOLFIRI with BEV. So triplet has a better PFS and OS advantage when we have continued with BEV. However, it comes with a toxicity profile. There was another study of MACPET. This is interesting. FOLFIRI and cetuximab continue with cetuximab, FOLFIRI and cetuximab continue with bevacizumab. So there was a switch of maintenance therapy in this MACBET trial, which says that both of these trials are well accepted. There is no disadvantage of even switching. If there is a toxicity of one maintenance therapy, you can switch to other maintenance therapy. You will be not termed as wrong practice. So this can also lead to a same PFS and OS benefit. However, there is another deeper trial. Deeper trial is a randomized 1:1 trial which says cetuximab FOLFOXIRI triplet with bevacizumab triplet, continue as cetuximab and continue as bevacizumab. In KRAS wild type, so cetuximab in deeper study had a PFS and an OS advantage over bevacizumab. So in KRAS wild type tumor, irrespective of the site, cetuximab in this deeper trial has a PFS and OS advantage. So we have data on both the drugs. So as per the quality of life, as per the cost-effective analysis, we can use either of this maintenance therapy for advantage of PFS and not OS all the time. So this is again a phase 3 triplet study, FOLFOX with panitumumab and triplet drug with panitumumab. There was no advantage of adding a triplet with panitumumab. There are some more attempts with the quintuplet study they were using triplet with Bev and triplet with Bev and Atezo. There was a PFS advantage with Atezo. However, this PFS advantage was given only to a deficient MMR tumors, not stable disease. And many other attempts of gefitinib use and anti-HER2 molecules and immunotherapy have been used in maintenance. And this is out of scope of this panel discussion. So any single point thing from our panelists that what would they like to suggest our viewers and other delegates what should be the best maintenance therapy?
I wanted to ask, in the studies where triplet has been used followed by maintenance, in all of them 12 cycles were used for FOLFOXIRI?
So it was 8 cycles. 8 cycles, and then they disintegrated into a maintenance therapy at 8 to 12 cycles, not 12 cycles always with triplet. Dr. Amit.
In adding to all those studies, the recent ESMO, there was another study of KRAS mutated type, panitumumab with sotorasib. It's just a 1 year of follow-up for PFS, and they showed a HR of 0.49.
So in KRAS mutated.
Yeah, KRAS mutated with panitumumab and sotorasib. So the answer is that whatever we are probably doing is correct. Whatever you are comfortable with is the right answer.
Yes, yes. So
the sotorasib was the G12C.
KRAS
G12C.
G12C mutation. So I think if everything is being discussed, we can thank our panelists for this wonderful participation, and we can move to the next, over to the organizers. Thank you so much.
Any questions? Okay, thank you. So I would now call next speaker, Dr. Krupal Shankar. Yes. So the topic is TKI for low and intermediate grade PNT. Dr. Krupal, take away.
So very good evening and a warm welcome to everyone. And at the outset, before I begin, I'm going to take this opportunity to congratulate the organizers for putting together this wonderful academic extravaganza, and also thank them for the opportunity. So I know when I looked at the topic, this is what the topic was given to me, role of TKIs in low and intermediate grade NAT. So I decided to look at what's actually new in it and actually getting to a consensus. We all know it's pretty rare. It's a rare conundrum, as I would call it. That was my first reaction. Pretty rare. What am I going to do? But I figured out that TKIs are not that rare as far as NETs are concerned. So I know putting it in a nutshell, I think this is as far as systemic therapies are concerned. We know we have biological agents, and then we have radioligand therapies, PRRTs, chemotherapies, but the focus of today's topic is going to be on targeted therapies alone. And that's where all the TKIs come in. Your multikinase inhibitors like sunitinib and surufatinib, which is already a license in China. Then cabozantinib, lenvatinib, pazopanib, axitinib. You have the data for all of this. I'm going to take you through that pretty quickly. And then the mTOR inhibitor everolimus, which has always been there. So just a bit of basic before we actually get into the topic. Why are we talking about targeted therapies or multikinase inhibitors or TKIs here? We're looking at blocking the downstream signaling pathways, be it the PI3K, KT, mTOR pathway, or even the other signaling pathways like the VEGFR, PDGFR, FGFR, and CSF1 receptor pathways. So that's why that's why we're looking at all these TKIs with interest, even in neuroendocrine tumors, because they're all confined to cell survival, proliferation, and cell signaling pathways. So this is a look at how far we have come as far as angiogenesis inhibitors in neuroendocrine tumors are concerned. So it began more than a decade back, right, 2011, where we're looking at sunitinib in pancreatic neuroendocrine tumors, and look at where we've come. We've moved through lenvatinib, phase 2 data with cabozantinib, axitinib, and surufatinib, which has already been approved in China. If you believe in Chinese data and Chinese molecules, that is. But nevertheless, jokes apart, I think, cabozantinib, we have the phase 3 data as of right now as well, the cabinet study, which is presented at ESMO 23. And moving forward, we're looking at combinations of IO plus TKI, Tizo plus cabozantinib, the cabinet study. I'll touch upon all of that as we move along, but right now we're in the era of TKIs, and not just TKIs alone, but IO plus TKIs as well. So, just one slide to tell you about all the TKIs and the data that we have. Look at all the phase 3 data with all these multikinase inhibitors, be it sunitinib, surufatinib, and cabozantinib. Sunitinib, VEGF, FGFR, PDGFR, c-KIT, and FLT3. An interesting bit of trivia probably, why is it called FLT3? We always say it's FMS like tyrosine kinase, right? But anybody knows why it's called FMS? What does FMS actually stand for? So I just looked it up. So it is interesting. It's called feline McDonough sarcoma. So that's what FMS actually stands for. Feline meaning cat, McDonough sarcoma's cat. So that's why she called it feline McDonough sarcomas, and that's how it come to be FLT3 inhibitors. Nevertheless, that was just a bit of trivia. So if you look at the median PFS, you're getting to see around 11 months, close to 11 to 13 months, be it across the board with all these multikinase inhibitors in phase 3 data. So I think that's pretty, and that's the data. So, as far as all these multikinase inhibitors are concerned, but we all must remember that it began with everolimus, and that's the mTOR inhibitor we're talking about for both pancreatic and the extrapancreatic neuroendocrine tumors. This is the RADIANT 3 and the RADIANT 4 data that we have. So you're looking at a doubling of the PFS, 11 versus 4.5 months, and this is the story behind how these targeted therapies actually began for neuroendocrine tumors. So these were the early recommendations from ESCO, and remember that I'll take you through that and I'll show you the current recommendation. This is how it was earlier as far as sunitinib was concerned and everolimus was concerned. Sunitinib probably for progressive pancreatic neuroendocrine tumors, and everolimus in patients even with extrapancreatic neuroendocrine tumors as well who had clearly progressive disease, and you could use it even after PRRT as well as far as everolimus was concerned. And again, moving on to typical versus atypical carcinoids. Atypical carcinoids, you'd want to use it higher up the order because obviously they are slightly more aggressive and they tend to progress on your somatostatin analogs that much more quickly. So that's again the list of all the data that we have looking at phase 3 placebo-controlled trials and a few select phase 2 trials as well with all these TKIs and multikinase inhibitors. And if you look at it across the board, phase 3 data, you're getting to see a median PFS of close to 8 months vis-a-vis 4 months for the control arm. So you're getting to see it doubled. And not only that, if you're looking at phase 2 data, probably the numbers here might be misleading because we always know that the phase 2 data doesn't always translate into what we see in phase 3. So if you think that's about it, there's more to come. And again, this is in just about pancreatic neuroendocrine tumors. And again, if you look at only pancreatic neuroendocrine tumors, here also you're getting to see a median PFS of close to 11 months across the board with all these TKIs, be it cabozantinib, sunitinib, or surufatinib as well. So I'm going to quickly delve into a bit of more of the data here. This is the CNET-P looking at pancreatic neuroendocrine tumors as well. And this is surufatinib again, multikinase inhibitor looking at targeting VEGF, FGFR, and CSF1 receptor. And the primary endpoint of this trial was again investigator-associated PFS. And they looked at both pancreatic, which was SANET-P, and then they had another trial called the SANET-EP looking at extrapancreatic neuroendocrine tumors as well. Not going to get into the statistical details here. Just remember that if they looked at investigator-associated PFS, and then that was to be later on confirmed by doing a blinded independent review committee analysis as well. So that's, without getting into too much of the statistics, I'm just going to tell you that. So this was the eligibility criteria, and look at it, well-differentiated grade 1 and 2 pancreatic neuroendocrine tumors, either locally advanced or distant mets. If they had progressed within 1 year, they could be taken in. And again, they should not have had at least 2 or more lines of therapy, and no prior VEGF inhibitors, and functional tumors were excluded. So look at it, again, grade 2, more than 85%, predominantly non-functional, 90%, almost all of them had liver metastasis, 95%, and prior therapy in 2/3 of these patients. So again, if you look at the median PFS, and this was clearly superior, the trial met its primary endpoint of improvement in PFS. It's almost tripled, 11 versus 3.5 months. So it's not just about having superiority complex. I think surufatinib definitely was superior to placebo, nevertheless. And if you look at all the subgroup analysis, clearly you could see that there was a benefit across the board with all these subgroups, be it just the grade of the tumor based on grade or prior therapies as well. Could see that surufatinib definitely did much better. And again, the blinded independent review committee also did concur with the investigator-associated PFS of seeing that the PFS was triple, 13.5 months versus 4.5. What about extrapancreatic neuroendocrine tumors then? So you get to see a median PFS which was more than doubled, 9 versus 4 months, and again across the subgroup analysis as well, albeit exploratory subgroup analysis as well. This forest plot clearly shows that surufatinib was much better off. But then again, there was this, like I said, this was the post-hoc sensitivity analysis for the PFS, looking at, did the investigator-associated PFS actually translate into blinded independent review committee analysis as well? There was a difference between that, and probably these are the reasons as to why there was a difference, because the prior local regional therapies could have been challenges for the central reviewers because there was a discordance there, and 30 versus 20%. And again, since I said earlier, more than 95% of them had liver lesions at baseline. So classifying them as new lesions or taking it as progression or non-target lesions could have also led to the discrepancies between the investigator-associated versus the blinded independent review committee. So, that was my reaction. How can you say that's just not statistical significant? I think this is very clinically significant. And looking at the response rates, 20 versus 2%, clearly to the tune of benefit with surufatinib when compared to placebo. And again, as you would see commonly with all these TKIs, hypertension, proteinuria, and diarrhea were the chief concerns, grade 3 TIs, if you're talking about more than 20% treatment emergent adverse events. And moving on to the last part of the talk, which is on cabozantinib, and this is the recent data that was actually presented at ESMO 23. Looked at both pancreatic, this is a cabinet study, looking at both pancreatic and extrapancreatic neuroendocrine tumors. And they also did, the good thing about this study is that they also included patients who had been prior exposed to sunitinib. So could cabozantinib be your option if somebody's progressed earlier on sunitinib as well? Well, I'll try and take you through that data. And the good part about the trial again was that they did allow for crossover, meaning once the progression was confirmed, they could go on to receive cabozantinib later. And the primary endpoint again here being PFS. This was again blinded independent review committee PFS. So this was a well-designed study, had both pancreatic and extrapancreatic neuroendocrine tumors, 2:1 randomization, predominantly grade 1 and grade 2, and very 10% grade 3 and less than 2% poorly differentiated neuroendocrine tumors in the extrapancreatic subset. All of them were heavily pre-treated, at least 2 to 7 median lines you're talking about, at least 2 to 3 lines, and a maximum of up to 7 lines of therapy as well. And they were stratified based on prior sunitinib or not, but we don't have the results from that cohort of patients who had prior sunitinib. But this trial ended early because the Data Safety and Monitoring Board recommended that the primary endpoint of this efficacy analysis was met, and that's why, I think this is, cabozantinib is here to stay. It's probably, an idea whose time has come. I think we should really look at using those TKIs in practice as well. So this was the response rates again, both in pancreatic and neuroendocrine, both in extrapancreatic as well. You could see the response rates clearly more than tripled. And the median PFS, absolutely, there was a huge benefit, more than doubled as far as both extrapancreatic and pancreatic neuroendocrine tumors. There was a criticism saying that probably, as is the norm with all these current day trials, was the control arm weakened, which is why it's not doing as well as it should have done. But again, I think, there are reasons as to why that could have happened, because there are changes in the tumor biology as well. Because remember, this year you're talking about neuroendocrine tumors, which are grade 1 and 2. So they could have gone on for a long time from enrollment, and most of them had a median of even close to 2 to 7 lines of therapy. So that you're talking about heavily pre-treated population here, which could probably explain why the control arm was probably underperforming, or was only 3 months. Nevertheless, this is the overall survival data, which is completely not yet mature. You're not yet able to see a difference which is statistically significant, although be it in the pancreatic neuroendocrine tumor subset, this was numerically significant but not yet statistically significant. And that's probably because the data is not yet mature. The adverse events, again, as was rightly pointed out again earlier as well with the other TKIs, hypertension, fatigue, and diarrhea are the chief concerns. But we don't have the quality of life data yet from this trial. And how do you look at placing it potentially as far as extrapancreatic neuroendocrine tumors are concerned? Post 2 lines of therapy, I think most of us would agree that we would do a somatostatin analogs and then your PRRTs first and second line therapies before you're looking at going on to TKIs. So that's where I would look at placing it, and it's just not always about NCCN. I think, there are various other guidelines as well, and our own Indian specific NCG guidelines as well. So I'm sure Viraj would agree. So anyway, looking at pancreatic neuroendocrine tumors as well. So look at where we would place the TKIs. If you think you have somebody who's progressing rapidly and who's pretty symptomatic and who's even progressed even on prior sunitinib, because that's where the cabinet data becomes interesting, even though we're still awaiting the results from that cohort. You could still look at using cabozantinib as an option in patients who have progressed on prior sunitinib. So moving forward, I think this is the future, and this is how it's likely to roll out in the future. IO plus TKI combinations. So this is the Cabatin study. This is again basket study looking at this particular combination of IO, TKIs, all these are subsets. And they even looked at it in paragangliomas, pheochromocytomas and paragangliomas as well. And that's the PPGL cohort that we're talking about. And we had the first MAP trial, which is recently published phase 2 data on Lancet, looking at sunitinib in pheochromocytomas and paragangliomas as well. But I'm not going to get into the details of that study. Now remember that IO plus TKIs are here to stay. And interestingly enough, the response rates seem to be much better off with IO plus TKI combinations rather than just IO alone or an IO plus IO combination. So this is very early data yet, albeit only phase 1 but 2, and we still have to wait until we actually get more robust data or phase level 1 evidence. And you really can't keep immunotherapy out of any solid tumor talk that we give. So it's absolutely very hard right now. And so with that, I'll conclude and say thank you all for your patient listening, and happy to take any questions if there are any. Thank you.
Any questions from the house? If not, I have one since we have 2 minutes. So for the audience and me, can you place everolimus in practice? So can you tell me which patient would you use and when, which line? So you said SSA, but in your guidelines you said everolimus in first box.
Yeah.
So which is that patient?
Yeah. So one of those algorithms was looking at patients who had a typical carcinoid versus an atypical carcinoid. If you're looking at patients with an extra pancreatic neuroendocrine tumor in that subset. So if you have somebody with an atypical carcinoid and who's progressing rapidly after your first line of therapy, they already are candidates, like for example, be it a lung or even a small intestine or GI and ET. Those are patients who could, theoretically speaking, based on the recommendations and guidelines.
I meant first line. Is there
line.
any patient where you would not do SSA but do everolimus?
No, unlikely, especially if you're talking about grade 1 and grade 2 NETs, where they're not going to be very symptomatic. I would always look at using a somatostatin analog as my first line of choice of therapy.
What about if your patient does not have DOTA uptake?
So if you're looking at the Krennig scale or the Krennig score, based on which you could classify them as 1, 2, and 3, 4. If they don't have any uptake, even then, I think the thing is,
do SSA in that?
Somatostatin analogs, for example, I will also look at whether they're functional or non-functional as well. So if you have somebody who's got a secretory tumor who's functional, meaning, with the chromogram elevation, then, I would definitely look at using
non-functional, non-DOTA uptake, but low grade. And I'm sure Dr. Lele will agree that 5 to 10% in our practice are there, like pancreatic especially. So I think those are the ones where TKIs precede our standard somatostatin analogs. That was my understanding. What is your thought?
I see. I agree. Your point is very well taken, Viraj. But the problem is, I think, if you look at all the data, so Radiant 3 and 4, which I just showed you right now, as far as the approval for everolimus goes, none of it was in the first line. So it was always in the later lines of therapy. And even with all the TKI data that I showed, none of it was right up front. It was always, post 1 line or 2 lines of therapy.
Sure.
Which is why, and we have the NETA-2 data, like rightly, combining SSAs with PRRT right up front. Has shown a PFS benefit as well. So, we are spoiled for choices. Everolimus, not an easy drug to handle. We all know at the truly approved dose of 10 milligrams. I think none of us would be doing 10 milligrams. We would do 5 milligrams at best and hike it up to 7.5 if your patient takes it well or if you're lucky enough. Or even sunitinib for that matter becomes another option, albeit at a slightly reduced dose, maybe 37.5 or even 25 milligrams. 2 weeks on and 2 weeks off. I think those are options that I would contemplate. Everolimus, the one reason why I'm probably very hesitant is because of the toxicity concerns. Stomatitis, hyperglycemia, diarrhea. We've had fatal instances of interstitial pneumonitis as well.
Sure.
So I think those are my concerns, Viraj.
Great. Thank you.
Cap time in between.
So again, the Indian data, when you talk about TMH data where they've looked at using CAPTEM in combination with PRRT as well. So if I've started off with a somatostatin analog, and if I've then my second line of choice is probably a PRRT. In that subset, I would probably look at combining both. If the patient has got a large volume of disease, symptomatic progression, then I would probably look at combining it with CAPTEM. So I think that's probably my working algorithm as far as whether I would go with CAPTEM or somatostatin analogs are concerned.
So you, in your institution, do you use CAPTEM with PRRT? And it's very difficult to give temozolomide in that PRRT. The day 10 to 14 temozolomide is too difficult to do.
Yeah, Absolutely, it is quite tough, but depends on the patient profile as well. Like for example, if you have a patient who's quite fit enough, who's tolerated therapy, and
They are fit. They are usually fit patients.
True, but I think I would definitely. I have used it in a couple of our patients. Sure, Viraj would also probably want to add.
So even in Jaslok and high volume centers, for high grade NET who have SSTR expression, these are the patients, and especially pancreatic primary, they typically go with CAPTEM combined with PRRT, because PRRT again for pancreatic neuroendocrine has until last year was never in limelight until the later lines. It's not as sensitive as you would expect in small bowel NETs. So yes, for pan-nets, we do sometimes combine CAPTEM and PRRT.
Agreed. I think the ECOG study as well, where we were looking at using it as first line as well for CAPTEM for grade 1 and grade 2 neuroendocrine tumors. And probably for higher grade neuroendocrine tumors, you would probably look at, and if the disease is more aggressive biology, the volume of disease, burden of disease is high, probably that's an ideal base case for us to combine PRRT with CAPTEM. Otherwise, PRRT with lutetium, like with somatostatin analogs would be my choice.
Thank you, Dr.
Thank you.
We'll move forward and we'll take more questions during panel discussion. And let me introduce you Dr. Vikram Lele sir, who's going to tell us the role of PRRT beyond lutetium. We all know lutetium. Everybody, all medical oncologists knows lutetium. You enlighten us, sir, beyond lutetium. Thank you, sir.
Thank you, Dr. Viraj. PRRT has been practiced in India for almost 8 years or more, probably 8 to 9 years, and till it got FDA approved just in 2017. We have been at it for much long before that, and it has now been well established, especially after the NETA-1 trial, where it was shown to have a much higher progression-free survival compared to LAR, 48 months versus 8. So it has a progression-free survival. It is very good at symptom control, especially in functioning NETs. It improves the quality of life, and it has a very good safety profile. All this has put it well within the second line after you are giving LAR. And this has been our experience also. We end up arresting the disease in about 80% of the cases. We have a complete remission in around 1 to 3%. We reduce the burden of the disease in about 20 to 30%, but whatever you do, 20% will progress. So this is the sort of profile we have. The toxicity is fairly good. We don't get grade 3 or 4 hematological toxicity. It occurs only in about 1% with neutrophils, about 2% with platelets, and lymphopenia is fairly more common in about 9%. So basically, symptom control, as you can see this study, we get very good relief. Quality of life, abdominal pain, diarrhea, flushing, fatigue, weight loss, all these are very well controlled with the help of PRRT. The response, I'm just giving you a brief overview before I tell you why we need to go further. The response to PRRT can be gauged by several factors. There are unfavorable response factors like elevated inflammatory markers like high CRP, neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, presence of ascites, marked liver metastatic burden, more than 5 skeletal metastases, and FDG PET avidity. All these indicate a poor response to PRRT with lutetium. Favorable outcome will be with very high gallium dotated avidity. All of you know the Krenning score. More than 2 is the minimum, 3 and 4 are the ones which are going to respond very well. And the primary pancreatic NETs tend to respond better, though we are getting good responses even with thymic and the mediastinal and all the other genomes. So in spite of all this, we come across a lot of patients who are primarily refractory to PRRT, or who, after a good initial response with a progression-free survival of about 48 months, relapse. They come back again. So this is the situation where we need to look beyond a lutetium PRRT, and there have been several attempts to find out why this occurs, why this resistance to PRRT occurs. There and these are the mainly studies which have explored the possible reasons. The epigenetic downregulation of the SSTR expression does occur in a significant proportion of cases where it stops expressing. As time goes by, the expression of SSTR goes down. As you know, with lutetium, we have, with PRRT, we have 5 types of receptors, 1 to 5. The 2 is the one which is most extensively expressed. Then there is an enhancement of DNA damage repair pathways. What we are doing with lutetium is we are causing single-stranded DNA breaks, and we are causing very rarely double-stranded DNA breaks. And the repair enzymes are quite active. And once the tumor gets exposed to it, it sort of enhances its own DNA repair pathway. And this, as time goes by, may reduce the response to PRRT. There is also a hypoxia-induced pathway which produces hypoxia-induced factor 2 alpha, which causes hypoxic sort of situation where the response to PRRT goes down. And so there have been several now interesting studies where the HIF2 alpha inhibitor belzutifan has been used. And by using this, the response to PRRT has been shown to be improved, where you are blocking the hypoxia-induced expression. Then finally, there is a radiation-induced epigenetic gene expression modification. And you have this histone deacetylase inhibitor, varinostat, which if you use, will cause the expression of SSTR receptors to go up. And then we can again restart using PRRT with lutetium. So these have been explored, and several attempts have been made to try to overcome. Many of these have resulted in now combination therapies beyond only lutetium PRRT alone with LAR. Mind you, most of the lutetium therapies are with LAR. They have to be combined. We do not give it alone. Both have to be combined, and the LAR has to be continued. The standard protocol is we are giving 4 cycles of PRRT at an interval of 2 months along with monthly LAR. And once we stop the PRRT, the LAR should be continued, probably for a year or even more. And we have been finding further response after continuation with only LAR after 4 cycles of PRRT has been given. So combination therapies have been now tried, like lutetium PRRT plus pembrolizumab, nivolumab, Captem. Somebody talked just now, there is a trial going on at the Tata Hospital, the precedent trial, where you are combining Captem and PRRT, especially in those who are positive on a FDG scan. So nowadays we routinely do gallium DOTA scan along with FDG scan, and those who are positive on FDG, they do a sandwich therapy regime where in between the cycles of PRRT, they put in the Captem. I just heard that it's not very easy, but it seemed to be working fairly well at the Tata Hospital. Then we are combining lutetium PRRT plus everolimus, that's the Nettle trial, lutetium PRRT plus triapine, which is the anti-cancer drug, plus olaparib, inhibitors, the DNA repair mechanism will be blocked, PRRT plus pepsosertib. And so many trials are going on using all these combinations beyond just lutetium PRRT alone. And now we are looking at something more exciting, like what we are using with PRRT, that is the octreotate or DOTA-TOC or DOTA-TATE. These are SSTR receptor agonists. Now we have antagonists to the SSTR receptors. Now these antagonists are much more avid than the agonists, because the antagonists are attaching to the SSTR receptors which are both active and inactive, while the agonists are attaching to the SSTR receptors which are only active. So those patients in whom the SSTR receptors, the gallium scan is negative with gallium DOTA-TOC, DOTA-NOC, DOTA-TATE, these are the 3 imaging agents which we use, they light up beautifully when we start using antagonists. The antagonists like salatriotide, tetraxan, there are many new antagonists coming up, NM3, when we label with them, and now they are starting to use them as therapy also. We combine these antagonists with lutetium, and they go, and only problem is they don't get internalized. While lutetium PRRT, it gets internalized into the cell and it destroys the cell. While with the antagonist, it stays on the surface, but it stays there for a sufficiently long time for the radiation to go and destroy the cell. So using antagonists is the next line therapy, and trials are going on using antagonists also. And this gives you sort of the ongoing with various things. And apart from combining it with the therapy, with so many other drugs, we are now looking at changing the lutetium. Instead of using lutetium, we are now going to start using other radioisotopes. Now here is just a case to show you. There's a 46-year-old female who we gave 4 cycles of PRRT. Then you see that pre-PRRT, post-PRRT, not much difference. It became a stable disease. It did not progress. She came to us with progressive disease. Then we continued to give her LAR. And when we followed her up, look at the response. Everything had just vanished. So we recommend that we continue LAR injections. So now, what are the other radiopharmaceuticals? Now, what we are using is lutetium. Now, lutetium is a beta emitter. Beta emitter is lethal. Beta rays goes and destroys. It has a sort of a deep penetration of about 2 millimeter. And we have 2 beta emitters which are used in PRRT. One is lutetium, all of you know. One is yttrium-90. Now, yttrium-90 has a deeper penetration. It has a penetration of around 11 millimeters as opposed to 2 millimeters with lutetium. Yttrium-90 also has a much higher energy. It has an energy of 2000 keV as opposed to only 0.5 of lutetium. It's a much powerful isotope. So initially, yttrium was used as a first isotope with PRRT. The problem with yttrium, because it is penetrates so deeply, it causes a lot of kidney toxicity. And the incidence of kidney toxicity goes to 9% as opposed to 1 to 3% with lutetium. So we usually keep yttrium reserved for big tumors, tumors which are 5 centimeters or more, and where we want a higher tumor kill. Smaller tumors are very well responsive to lutetium because its depth of penetration is very low. It's just 2 millimeter. But now we need a tracer or a isotope which is now alpha emitter. Now what are these alpha emitters? These are like elephants. They are huge, very heavy atoms, but they have huge energy. And they penetrate very, very less. They have a path of only 10 to 100 micrometers as opposed to around 11 millimeters with yttrium. But they dissipate their energy in that small area which they go. And this is called as a linear energy transfer, LET. They have a very high LET, 80 keV per micrometer, as opposed to only 0.2 keV per micrometer with the beta emitters. So it's like the elephant in a china shop. It just goes and destroys everything which is near. It's a very powerful, it is 200 times more effective as compared to lutetium. So now the interest is using these alpha emitters, combining them with this DOTA and use it for therapy. Now there are several alpha emitters. Of the most important among them is actinium-225. There is also lead-212. There is also astatine. There is bismuth. Of these, actinium is what we have the largest experience in India. In fact, at the All India Institute, there is a huge data which has come up, one of the largest series in the world. I'll be talking about it. This actinium, the problem is, it is available sporadically. It is manufactured in Germany, and after all the world has been given actinium, they throw a few pieces at us in India. You know, we are the last priority. That is the unfortunate part. It's extremely expensive. It costs something like 6 lakhs to 7 lakhs per cycle of actinium, as opposed to 1,45,000 to 2,60,000 for one cycle of lutetium. But actinium, surprisingly, India is sitting on thorium, which we have the largest source of thorium in the whole world. And actinium comes from thorium. So we can be the world leader in production of actinium. And our society, we are trying to impress upon, Make in India seems to be the big thing now. We are trying to impress upon the powers that be, that we can start production of actinium. It's not beyond us. Our scientists are fantastic. We have had talks with the Bhabha Atomic Research Center, they are capable of producing actinium in India, and we can become the leader and supply everybody instead of getting scraps thrown at us from outside. So with this, because the actinium is so powerful, it causes double-stranded breaks of the DNA, and the alpha-emitting PRRT has the potential to cause significantly higher, estimated 20-fold amount of double-strand DNA breaks. And due to the more localized and the high energy delivery provided by the alpha particles to the targeted tissue. And when you have so many rapid double-stranded DNA breaks, it causes apoptosis in the cell, and it does not allow the cell to recover. It sort of stuns it, and its repair mechanisms also don't come into action very quickly. So they circumvent the hypoxia signal pathways and upregulated DNA repair mechanisms that otherwise would lead to radiation resistance, as we see with lutetium dotatate. So that is the plus point of the actinium which we are using. There have been several studies now using actinium dotatate. The biggest, as I said, came from Dr. Bal at the All India Institute. They studied 91 patients. It's early days. We don't know how much, but whatever data they have shown, they have got really good responses. They divided 3 groups, one who had relapsed after successful lutetium therapy, ones who were refractory to lutetium therapy, and one group who was drug naive. And surprisingly, the best response was the ones who had relapsed after successful therapy. They got the maximum overall survival with them. There's also one study from Kratochvil, which also showed similar findings. The only problem with that is that the renal toxicity seems to be a little more, because again, it's a very powerful isotope. Here are 1 or 2 cases before I conclude, how after one therapy with actinium dotatate, you can see the dramatic reduction in the disease burden after 2 therapies. Here is a 46-year-old heavily pretreated metastatic NET showing almost complete response after 1 cycle only of actinium dotatate. Everything has just disappeared. So to conclude, targeted alpha therapy using actinium somatostatin analog seems to be a promising therapeutic approach for metastatic or inoperable NETs, especially considering its preliminary efficacy and safety results. There's a currently ongoing trial, Action 1, which is designed to determine the safety, pharmacokinetics, recommended phase 3 doses of actinium dotatate, and we are eagerly waiting it. And as I said, we are trying to get the production started in India. Thank you for your kind attention.
Any questions? Sir, how many actiniums are we doing at Jaslo? Let's say in a year.
We have done only about 20 so far, but because actinium is no longer available at the moment, it is off the market for everybody. Bal has done the maximum around 90. It's also done by Dr. Ishita at Fortis in Delhi.
Okay. Sir, you mentioned that ascites is not a good marker for PRRT in general. Yeah. I heard you once, a couple of years back, somebody is doing intraperitoneal PRRT?
Yes. Well, Dr. Kallur at Bangalore, at the HCG Center, is a big fan of intraperitoneal or local arterial in the liver for hepatic disease. Intraperitoneal he has tried, especially with a new agent called FAPI. I don't know if you know, but FAPI is a fibroblast activation protein inhibitor, which goes to all the cancers. They express FAPI. So we can label FAPI with gallium and we can treat with lutetium FAPI. So he has treated ovarian cancer, which has metastasized in the peritoneum, which has failed all chemotherapy by local intraperitoneal injection, and he's got very good results. Though the logic escapes me, because when you inject intravenous, it goes to all those cells. There is no particular...
published, sir?
No,
this experience is not published.
It's not yet published. These are anecdotal cases. Once he gets a critical level, then he will do that.
Sir,
thank you.
Sir, one question, sir. Thank you for the nice presentation, sir. Actually, is there any criteria how to select alpha emitter versus beta if we have both options available?
Yeah, currently you will use alpha only when the beta has failed, or you have treated beta and the patient has come with a relapse later on. The data from AIMS has not shown really great result for drug naive. If you're using it the first time, the results are almost the same as with lutetium. So it's not working wonders in drug naive patients. You will reserve it for those who have failed with lutetium therapy because of cost factors and availability.
Right. Thank you very much, sir. Let's move on to the next session, and all these questions we want to take for in panel discussions of pancreatic neuroendocrine. And to lead this discussion, we have Dr. Ashish Singh from Vellore to moderate this session. Thank you. And let me call the panelists: Dr. Soumya from Bhubaneswar, Dr. Preeti from Nanded, Dr. Abhishek Singh from Lucknow, Dr. Tanveer Maqsood sir from Surat, Dr. Srinath from Hyderabad, Dr. Sunitha from Hyderabad, and Dr. Gadipalli from Hyderabad.
So good evening.
So all 5 medical oncologists, 2 nuclear specialists.
Good evening. Thank you all for being here. I know there's a lot of interesting sessions going on in adjacent rooms, and a lot of people are even over there. So I think I should thank the organizers for keeping this, allotting 3 sessions for this so-called rare cancers, but I know all of you in the room would agree these are not rare. We usually come across in various forms neuroendocrine tumors, and I think it deserves more attention than what we usually provide, and so that's a good start. So welcome my panelists. I wish we had a surgeon any surgeon in the audience? No. Okay, so maybe Dr. Viraj will be my surgeon.
Yeah, I'm a big fan of debulking in neuroendocrines.
Okay, so this is supposed to be a case-based discussion, and I think the previous 2 talks have elaborated on the data, and we all know that all the data which we have seen looks impressive, right? I mean, you talk to anybody who treats this disease, they'll swear by what they do, and they say, what I do definitely works, right? You ask a medical oncologist, you ask a surgical oncologist, you ask a nuclear medicine physician, you ask a surgeon, you ask an intervention radiologist. So basically, is it actually that our therapies are so effective, or is just the biology of the disease that the patients do well in spite of whatever we throw at them, right? And then having said that, we all have lost patients to this disease, right? We all have seen how they come with failing liver, uncontrolled hypoglycemia, carcinoid heart disease, right? And obstruction, bleeding, and sometimes it's a little too late, and then we feel, okay, maybe we should have acted well ahead of time. So just to start the discussion, this is a patient we've seen 3 months back, a young lady, but just that she noticed a change in her bowel habits, and she works in a bank, so this was troubling her, like diarrhea 3 to 4 times a day. And she said, okay, let me go, occasional ball rolling sensation, some pain. She said, okay, let me go have a checkup. And the checkup initially was an ultrasound which picked up something in the epigastric region, and which led to a CT scan. And the CT scan showed that there are lesions on the lesser and greater curvature of the stomach. There's something seen around the duodenum, and there are also some lymph nodes and some lesion in the pancreas, and also maybe a faint lesion in the segment 4 of the liver. Now, so all these would probably led to further investigations. So because there was something seen in the stomach, you see this is an upper GI scopy. What you see in the first picture is the stomach. We don't have a radiologist, so any of the panelists would want to describe what you see? We have nuclear medicine physicians, so this is an endoscopy picture. So basically, I'll just say, obviously this is not normal mucosa, right? These are multiple nodular lesions all over the stomach. At least on the first picture, it's all over the stomach. And when you go down, antrum was a bit spared. And actually, when you peep in the second picture, you see there is about some few nodules in the duodenum. So, and each of these are like ranging from 1 to 2 millimeters all the way up to 8 to 10 millimeters. And then the next thing was to look at the cross-sectional imaging, and the cross-sectional imaging, as I say, what we were seeing, something around the duodenum was actually a very large. Can you see my pointer? No. Okay, 1 minute. Was a very large node. This is almost about 7 centimeter in size. And this is again, we are seeing part of the distal stomach duodenum, and this whole thing is the thickening. And so here, as obviously the endoscopist would do a biopsy, and this was done elsewhere. Biopsy was reported as a carcinoma which is synaptophysin chromogranin positive. So Ki67 on whatever report she came in was 1 to 2%. So was labeled as well differentiated NET, and then she comes to us. So let me start with my nuclear medicine colleagues. We have Dr. Sunita and Dr. Tejunath, any one of you. At this point in time, does this patient need any further imaging, or this is okay?
For staging, better to do DOTA so that we can know whether it is DOTA positive or, and then as a baseline for next to plan.
Sure. So it's strongly recommended that a DOTA imaging is done, and staging. So we already know the lesions on a contrast enhanced CT. What additional information would the DOTA provide?
We do miss lesions like bone marrow and any extra thing. See, it's only CT abdomen that is done. So
All
burden
right.
of the disease, we have an idea. And also see pathology, maybe heterogeneity, the place where you have done biopsy, we have seen regularly. Both grade 1 and grade 2 lesions are there. So prognostication is also
two
important.
important points. One is that we can look at the entire body. Second point you brought out is
Tumor
you would
heterogeneity.
like to look at the intensity of your
Yes.
DOTA uptake.
Yes.
And that
Prognostication.
may tell you about biology of basically the heterogeneity of this disease, that what's going on in pancreas may be different from what's
From
going
the
on in the
liver.
liver. Okay, and so Dr. Tejunath, how would you report this heterogeneity? I mean, do you use a scale? There's something called Krennic scale. So what does that mean? I mean, how do you do it?
So basically, Krennic scale is to look at the intensity of uptake with regard to the liver and the spleen, and this was actually designed for the planar imaging, which was initially done. There's no DOTA gallium available at that time, so this is basically look at whether the uptake in that lesion is less than the liver uptake. Equal
So
to
does this correlate with grade, or does it?
Higher the uptake, it is better, higher, well differentiated. If it is poorer the uptake, it is poorly differentiated.
So do you use this for just to kind of figure out what's going on, or you also use it for treatment decisions?
Treatment decisions, yes. Treatment decision, we have to have the Krennic score to know whether these lesions are Krennic 3 or 4, so that they respond well to our PRRT than the lesions which are otherwise.
So you classify in your report as high expressor versus low expressor. So for the audience, for the students, what is high expressor?
The Krennic's 4.
Okay.
Krennic's 4.
Okay.
Krennic's 3 and 4 are the higher DOTA, that is somatostatin receptor expressing tumors, whereas the others are low expressing somatostatin receptor expressing tumors.
And is that something only you can do it on your console, or somebody walks in with a picture like this, and can Dr. Viraj or me, who just looking at it?
It's a visual scoring system.
Can we do it? Can we do it?
It's a visual scoring system. You can look at the spleen and liver uptake, and then you can judge the Krennic score of the lesion.
Okay. So that's something I learned today. So this, how will you score this as? What will you score this as?
It's 4.
Okay, so it's high expression. So that's okay. That's anything else. Also, so now my Medong colleague, Dr. Preeti, biopsy is done. Now I showed like this patient has got disease in so many sites, right? You've got pancreas, you've got node, you've got stomach, you've got liver. So she already has come with slides and blocks from the gastric biopsy, and that was reported at NET grade 1. Are you happy with that, or you want some more pathology to be studied?
No, grade, proliferation rate, and scan.
So basically what I'm trying to ask is that when patients have disease at different sites, and it's extremely important for us to look at the grade, right? The grade, the Ki67. So how do we know which site the biopsy should come from? Is it the most easily accessible site, or we should go back to the nuclear medicine physicians and say, okay, which is the tumor with the highest uptake, and the needle should go there. Anybody else? Dr. Abhishek, what do you think?
Sir, any site would, because most of the time patient comes with biopsy.
So like for this patient, would you insist on a USG guided liver biopsy or a CT guided node biopsy, or you're pretty okay with just a gastric mucosal biopsy?
I'm okay with this, but if the expression, if the nuclear medicine consultant says that because of the heterogeneity of the disease in this particular case, if something, some site other than this stomach lesion is having more uptake, probably if it is accessible, probably one biopsy from there also would do.
Dr. Sunita, sometimes I have seen people propagating, doing FDG PET also in addition to. So do you think for this patient, would you advise an FDG also?
Details about this one. If the liver lesion is not picking up, definitely next year we'll plan FDG to know.
Okay, so what you're saying, if you see something on a contrast CT but don't see on a DOTA CT, you should do a PET CT. Okay, yes. Okay, so that's one way to go about it. So now this patient, we have tissue from two sides. One is from the stomach, other one is from the duodenum. Also, they've done EUS FNA. And so if you look at both the sides, similar description. The mitotic activity is inconspicuous, and the MIP proliferation is from the stomach is 3 to 4, from the gastric body is 4 to 5. So Dr. Soumya, how do you interpret MIB in this disease? Do you draw boundaries?
There is a classification for that. The WHO 2022 gives that.
Right.
That it takes into account the mitotic and the Ki67. So if it is less than 2 or 2 to 10 and more than 10. So more than 10 is something neuroendocrine carcinoma, and less than 2 is grade 1. So that's how we classify the.
True. So for the students here, I think it's go back and make yourself familiar with the terminologies. So you have neuroendocrine neoplasms, which should be called NETs if they are well differentiated. They should be called NECs, carcinomas if they're poorly differentiated. And you can have a well differentiated tumor but a high grade tumor. That's different from a neuroendocrine carcinoma, right? And then in the pathology, their description is separate for lung, separate for pancreatic, and separate from they say the midgut, which is the small intestine, right? And then all these are important because you may have a grade 3 well differentiated NET, which is a much better prognosis than a neuroendocrine carcinoma with a low or intermediate MIB. So now, okay, so this is one picture I put. So this kind of puts what you can see there is the large uptake in the stomach, large uptake in the node. The two dots in between are the pancreatic uncinate smaller lesion, pancreatic body lesion, and there's one lesion in the liver. So I don't have a surgeon, but we are all blessed to work with very talented surgeons. So Dr. Viraj, what would you?
So you also showed the endoscopic report, which actually changed the whole concept. The whole stomach is studded with.
Correct, and that's what you see in that. Whatever there you see on the left hand side is actually the stomach. Yeah.
So, yes, if resectable, I would resect it.
The idea is that in liver, again, they have to see that whether they can resect it out, how much up to 90% was the earlier threshold, now it is coming down to 70%, and whether they can, whether this is going to, in future, this is going for any obstruction or any kind of a pain or something is going to be there in future. So the surgeons, again, the threshold is coming down. So earlier it was something, the cutoff is coming down. So if, again, there is a certain subset where you can keep on only wide resection. So you do not go for Whipple's also. If it is a very small one, not this one, but a very small one, then only wide resection might be sufficient if you do, it is grade 1.
So Dr. Tanvir, what do you think? So this is exactly what my surgeon called me and asked me, say, I want you to look at this patient. Till now the patient is with the surgeon. Then when he looks at this, he says, I want you to look at this patient and tell me whether I can do a Whipple's and I can remove the node. I can probably look at the liver intraoperatively. And if everything goes well, should I do a gastrectomy also? That's the question to us. And then he's saying, okay, my next question to him is, what about the morbidity of all what you're doing? Is it worth it, Dr. Tanveer?
I think in this case, surgery will be very morbid, so better to start with octreotide.
Okay, so anybody here who would say, Dr. Bharat, would you do surgery? 45-year-old fit lady.
Thing is, somebody who has, even if they're 45, to do both a gastrectomy and consider Whipples in the same setting, I'm not very convinced about that. See, if it was just the pancreas, you said there is an uncinate lesion.
Yeah, so those two dots in the middle,
Uncinate.
one
So
is
you have
uncinate,
to
another
use a
on
Whipples
body.
and a gastrectomy if you are going to get these patients generally do well with some systemic therapy and they go on for a long time.
Yes.
I would
So,
not do if there was no uncinate process lesion or if there was no gastric lesion. That is different, but to do gastrectomy plus Whipples is
So that's
overkill.
another thing. So the audience, everybody feels that these patients do well.
They do well.
My panel, anybody wants to differ from that? What's the chance that this lady, she's only 45, she will die of this disease in the future?
So just one point, what was the gastrin level on this? And number two, did we do men testing on this?
Yes, I'm coming to that. Yeah, so the gastrin, I don't think we did. She had no symptoms. We did not chromogranin also, I'm not sure. I mean, I haven't yet started treating this lady.
This is not Zollinger.
No, this is non-secretory. So you asked about men testing. So if I just point out in the same imaging, if you see, she has a pituitary tumor as well. And okay, that may be physiological, but she did have. And then when we worked with her calcium and all, she's hyperparathyroid, and we have. I mean, I don't have a genetic report, but it appears to be that she is part of that 20-25% who may be part of men one.
So the catch here is 2 neuroendocrine primaries in one patient. We should think about hereditary.
Sir, may I add on? Yeah.
Oh, the surveillance protocol. So a surgeon who is expert in this neuroendocrine, I think so this won't be a difficult job surgery wise, because you don't have to
So you are for surgery in this patient?
Yeah, absolutely.
So again, good discussion. So what is the goal of treatment here?
Sir, one thing before
she's asymptomatic. She just has diarrhea. Loperamide for loose motion. Yes.
Sir, because this patient has got probably 2 sides, gastrin level I would ask for, and then men 1 patients, they will be having slow growing tumors and they do well with the octreotide. So probably surgery definitely at this point of time I would rather wait.
Sure. So some in my panel is saying start octreotide and don't do anything. Now again, octreotide is all right. I mean, I didn't want to discuss too much data, but if we jump to octreotide data, this is the octreotide data we have, right? So we have the PROMID and we have the clarinet. We have, basically octreotide was initially used only for symptom control. Then they realized when we use for symptom control, the tumor also kind of was under control, and then the randomized trials were done. Then they decided 20 was a much lower dose, 30 is probably the right dose. And then they said even higher doses may even be better. And then in India we don't have, but there's something called pasireotide, which are probably better. And some people also say give it more frequently, give it continuously. All preparations are coming up. But then what we are seeing is that it just keeps the disease under control, doesn't give you response at all. And what you're seeing here is progression-free survival. So what does progression-free survival of 1 year mean in somebody who's 45 years of age and has no other symptoms? We have no impact on overall survival, right? So and then this is she's not having hypoglycemia or anything. So should we even give octreotide here? Anybody in the audience will say, and that's the most costliest therapy we have here.
And none of them included stomach. Remember, stomach nets, they don't do as well with octreotides.
Right, so yes, sir.
Sometimes what happens is that there is a role of debulking. Second thing is that the tumor grows sometime, and in future, whatever is some kind of borderline resectable can be unresectable and grows, and then patient does have a lot of.
If disease control is important, I think octreotide is one of the safest treatment we have. It may not be the cheapest treatment, but in terms of side effects and other things, that's a very good option to have.
and we would use 30 mg every month. And as Dr. Viraj was saying, there's hardly any data from stomach, and again, it probably is good for the mid-gut carcinoids, not so great for stomach and for the foregut ones, right? And larger volume of disease, of course, it doesn't work that well. And we discussed that response rates is hardly anything. So I see everybody is interested in getting a response because we want to get to surgery. So when we talk about response, I mean, all this was discussed in the previous talk. Dr. Kripa did a very good job. I don't have to tell you about the response and the PFS. So when we talk about response in somebody like this, what do we do? Shall we bring in chemotherapy? Shall we bring in everolimus? Shall we bring in sunitinib, octreotide, or shall we bring in the lutetium PRRT? Because we are all hoping there will be response and some surgery.
I think response-wise, PRRT would do a better job is what I...
Lele sir, any comment? So, PRRT as the first therapy for this lady. Because we are all impressed with the responses.
Symptoms, you said, diarrhea is there.
Yes, diarrhea is there.
So she is symptomatic, she has a huge burden of disease,
Right.
and you want to downstage the disease in future for the surgery. So PRRT would achieve most of your goals.
My Medong guys, how about capecitabine temozolomide?
So the option of octreotide plus everolimus or a capecitabine and temozolomide, if it is a grade 2, as it is. So both are there, and we can see for 2-3 months and then see how he is.
And then during the panel discussion, I was having a discussion ki while you're doing PRRT, in between you have 2 months, you're not doing anything, and patient is coming to you, and then you're very tempted to start an everolimus or a cape-tem. Is that the right practice, Dr. Viraj? I mean, should you do that? I mean, you're combining 2 toxic treatments together.
So currently the consensus is for well-differentiated high-grade who has FDG also. That's where we combine CAPTEM plus PRRT. Apart from that, for such patient, key index of 2 to 4, we don't do that.
Correct. And just finishing off with the chemo part. So chemo, how it started. So one of the first drugs, actually, we never had all these things historically, right? Just go back 15 years and all you had is streptozotocin. And small studies, just stable disease. Then we learned that temozolomide is, as a single agent, probably has the best responses. So the alkylator. And then there is some logic behind MGMT testing, right? Dr. Abhishek, do you do MGMT testing before deciding temozolomide?
Not routinely, sir. No.
So it can be a predictive marker, but it is not mandatory because even if you do not have MGMT, people do still respond. So how about, do you have to use a combination, Dr. Tanveer? Would you use a combination or you're pretty happy with?
Yes, we are using combination, CAPTEM.
Yes, and earlier I used to think whether do we really need this, but we saw the results of this small study, phase 2 study, but when you combine, the response rate goes up to 33%. And then you can see a PFS benefit and phase 2 trial. So don't give too much importance to the OS, but there seems to be some difference there. So
Ashish. Yeah.
Hi, sir. Yes.
So CAPTEM classically we keep it for grade 2 rather than grade 1. Ki67 here is 3. What you reported is. Yes, we are desperate to have the response so that they can reach the surgical table. I think combination of something will help, but at the same time, will NGS at this point of time help? Is something, because you showed all the table, will NGS be predictive in this patient? And as Viraj mentioned, I'm sure you must have shown to the surgeon. Did they feel that 2 separate primaries without major morbidity, will they be able to resect? It's a very interesting case.
So the question I also had for the surgeon was the same. She is not going to die very soon, this lady. Why can't you do 2 surgeries? Take one at a time.
Yeah, one by one.
Take one at a time. And so that's another question. Now, your comment about the grade. So this is like in this phase 2 RCT, there were some grade 1 and grade 2 both.
Yeah.
And whatever the small numbers, but whatever they could find that it works even
Equally.
it works even in a little lower grade. So that's there. So
important point. CAPTEM is not a good combo for extrapancreatic GI neuroendocrines. there has been multiple cohorts where if you take out the pancreatic neuroendocrine, the response rates and the benefit falls off dramatically.
Sure. And whether that has something to do with the MGMT, we don't know. I also came across a randomized trial where they do MGMT, and if MGMT is not there, they're actually randomizing to platinum-based therapy versus Captem or something like that. Okay, now coming to targeted therapies, Dr. Kripa has discussed all these in great depth. The best data we have for mTOR inhibitor is with everolimus, and not 1, 2, but there are 3 randomized trials. The inclusion criteria was different in all the 3. What I want to highlight is the results are impressive with Radiant 3, which was predominantly advanced PNET, but the Radiant 2, where there was a history of carcinoid syndrome, the data isn't that impressive. And if the OS data, if you see Radiant 2, there was probably a detriment as well. So it's not that everolimus is all, the story is not very rosy in everybody. So Dr. Abhishek, who's the patient? This lady, would you try everolimus?
Sir, everolimus, I don't use it upfront. It's basically tough drug to use. Many patients, 10 milligram definitely.
Your other option is equally bad, sunitinib. So maybe Soumya will have to check.
Yes. What happens is that most of the patients will be exposed to all the form of treatment. So the sequencing, what we do is we usually give a sandostatin LAR upfront, and
Sure.
in grade
So if
2
you have to use it,
and
so
then everolimus patient will be exposed to.
So for this reason, actually, it's all about. I mean, not in this patient, but usually you have a patient with incurable disease. You go one after the other, and the sequence. There is no trial which is actually is going to guide your sequence. Your sequence is all a clinical decision, right? Clinical decision. And if you have a frail patient who had a prior surgery, pancreas is removed, diabetic patients who's also having other, I would not want to use everolimus, right? You're going to be in trouble. And also for how long do you have to treat this with these drugs? It's still progression. It's not easy to stay on everolimus. It's okay in breast cancer where you have 4 or 5 months and then you get on. I mean, you get off. But here it's for years. And 10 mg everolimus is not easy. And the same problem with sunitinib. If you're hypertensive, you have other cardiovascular risk factors, you can't stay on this. So it's good to say we have options, but each one of them are very difficult options. And okay, so now going ahead to PRRT, yes. So I've convinced everybody that medoncs are bad guys, so you should not look at them. We should go to surgeons. We should maybe go to intervention radiologists. But then the issue with PRRT, ma'am, is how about that 1.5-2% risk of AML, renal injuries?
Sir, actually,
they're saying it's overrated. I mean, we talk about olaparib, we talk about all that.
See, from almost 10 years we are using, so it means it's less than 10%.
Okay. Okay,
So
and we do not have data that how people will tolerate sunitinib after PRRT. What about the proteinuria? What about, I mean, obviously the renal insult is low in the studies, but even if you see the approval, as of now the approval was after 1 line of therapy, right? So it wasn't
after sandostatin, PRRT.
So,
right.
My surgeon is not happy operating after PRRT because that causes so much of fibrosis, especially when you give multiple rounds.
Exactly,
So
and there
you
are
can
case
do
report.
1 round and then operate versus do 3 or 4 rounds. The surgeon is not going to be happy.
And another thing to keep in mind, especially for the foregut one, especially if it's at the root of mesentery, the fibrosis can itself cause ischemia, bowel obstruction.
See, this patient has lesion in body also. I think total pancreatectomy, total gastrectomy, and segment 4A lesion, where I think this patient won't go for surgery at all. So there is no point in downstaging, since we have to prolong the life without any symptoms and lesser side effects.
Sure. So I think our time is up, and I think we brought out the nuances of every treatment very well. I would like to thank my panel for doing that. And so it's basically there's no single answer or no single line of sequence for all our patients. We don't have predictive biomarkers. We don't have sequencing studies. So we go by functioning tumor, non-functioning tumor, small volume liver disease, large volume liver disease, right? Grade and mitosis. We go by the site, foregut versus midgut. We also go by the goal. Response is important, not important, right? And then we choose, pick and choose. I can't say that there is a single winner here. So if tomorrow in my MDT, my surgeons and my intervention radiology says we don't need you, we'll manage, I'm pretty happy to sit back and watch. And that's what I think most of us struggle to do, not to do anything. And with that, I will close, and thank you.
Thank you. Any question? We have 1 minute. We have 1 minute. Any question?
No. So Ashish first and then Viraj, maybe. We have 1 more minute.
So I would probably tell this lady, I will start, so you have diarrhea, you have some symptoms, start on octreotide, and as long as this scan remains the same, I don't want to do anything. Shall we go one after the other, one by one? Maybe start with the stomach and the node, and then look at pancreas and liver later. That I am more inclined more towards that. I do not want to use everolimus or sunitinib so early for her.
So you would go start with octreotide
and consider loco-regional treatment.
And consider surgery one by one. Okay.
Yeah, that's my gut feeling.
Agreed. I think we all would probably look at the same thing, because palliation at this point of time is not acceptable, according to me.
Excuse me. So to consider a local treatment, surgery for gastric first or pancreas first?
No, there's no one right answer. Okay, let's move on. Yeah. Excellent discussion on neuroendocrine. After a long time, we had such a long discussion on NETs. Great. Now we move on to a session called How I Treat, and we have 10-minute 3 talks. How I treat rare GI cancers. The first one is advanced GIST after imatinib failure, and for that, I call my co-host Dr. Vinayak Maka.
So
the stage is
time
yours.
is the essence of everything. So I came on stage before getting introduced.
Thank you.
So coming to the story, this is a story when we did our DM. This was a magical bullet, and patients would respond dramatically in PET scan. The question is how I treat post GIST. To do post imatinib failure, we have to know how to do it before. So it is a very peculiar disease. It has different heterogeneous molecular subtype, unique clinical behavior, and specific therapy. So this is the landscape of GIST. So most of them are KIT mutated. Around 10% of them are PDHR4 mutated, and non-KIT and non-PDHR4 they are SDH mutated, which you see in the children's. So coming to the KIT mutation, there are exon 19, 10. Most common is 11, exon 11. And PDHR4, you should know about a variant that is D842V variant, where the treatment differs from the generic imatinib. And other subset of patients where imatinib doesn't work is the other subset where the GIST is without c-KIT or PDHR mutation, which could be SDH or NTRK or BRAF mutated. So they are unique in subset. The takeaway for this slide is, for when you want to do a molecular study, for most of them NGS will pick it up. For SDH deficient disease, you have to do a IHC, and it has unique presentation depending upon the site which origins. So there are score systems which can give recurrence score. So you can see the scoring changes depending upon the tumor size, mitotic index, or primary location and tumor ruptures. You can see clearly this can help to predict the recurrence. So main treatment is surgery, and adjuvant is imatinib. You should remember that this is it has at least 3 years of imatinib has very good survival, recurrence-free survival. So only one thing you have to take away is that adjuvant treatment is differing. For patients with exon 9 should be given the 800 mg, and patients with PDHR mutated of variant of D842 variant, you have to do no treatment. It's a prognostic, it's good, so you don't have to give adjuvant imatinib. So other 2 subsets where you don't have to do imatinib is NF1 related and SDG expression deficits. So coming to the multimodality, the imatinib is standard of care for exceptions which I told earlier, and indefinite treatment only unless intolerance or patient preference. There is no treatment-free remission or something for concept for GIST. Surgical excision can be individualized depending upon the residual metastatic disease or progressive disease, especially if it is unifocal progressions. So surgical recession is it will take a clone out, resistant clone out. It can be done before after imatinib of at least more than 6 months. Up to 1 year, you can go with imatinib and then plan a surgical thing. The outcomes are not better after once you do after 1 year. So with this is the standard treatment. So what is my topic today is how do we address just post-imatinib failure? Already summarized, there are 3 things we have to look into closely. One is the presence of PDGR mutations. Second, there are multiple secondary c-KIT mutations, at least in 2 hotspots it occurs. One is at ATP binding pocket, which is at the exon 13 and 14. And another is activation loop domain, which is expressed on 17 and 18. Most of them are at this group and look separately with non-KIT mutations. So these are the variant, that is D842 variant, which for if you see, none of the drugs, that is imatinib, sunitinib, regorafenib or ripatinib are effective. Only treatment is aprimetinib, which is now available in India only on compassionate access. So the study which was done, the phase 2 study was in Navigator study, where they enrolled them into a single arm study of ipratinib. What you see interestingly is almost 80% response rates. If you go to your imatinib, it is response to the tune of 60%, and your PFS is up to the 22 months, whereas here the PFS is almost to the 34. This is a favorable biology which will respond nicely to the apritinib drug, and the response is maintained for longer duration also. So based on this, it has approval as for this exon 18 mutation, it is approved, and it is unique side effects are there which have to be watched out. Cognitive dysfunction, just like your lorlatinib, there are side effects which are CNS side effects. You have to be very careful. So toxicity has to be seen. Apart from that, there is a black box warning for the teratogenicity. This drug is not available in India. It can be available in compassionate access. So coming to the second one, where is in a c-KIT mutated GIST, where options of addressing, there's 4 mutations in 2 sites. One is ATP binding site pocket, which is coded by exon 13 and 14, whereas activation loop in 17 and 18, where we have 3 drugs available: sunitinib, regorafenib, ripatinib available, and DP variant also you can use apritinib. So you can see the sensitivity pattern. If you go for imatinib, you will expect a response rates of 68%. The response rates comes down for regorafenib and sunitinib is up to the single digit. And the PFS benefit is only for the 6 to 7 months. Whereas looking closely, these are the options available. Sunitinib is approved as of now based upon the study where they have found significant PFS benefit. And even though the PFS benefit is the tune of 6 months, there are side effects which has to be taken care for these groups of patients, but definitely it is the second line option for the patients who progressed on imatinib. Second is regorafenib. This is third line indications. The data is there for almost PFS benefit of almost 5 months and response rates of 4%. We are used to imatinib response, but this is some of the patients do well. And if you do dose escalated model, which you use it for colon cancer, there's no data for subset for this, but they do well. We have to take care of the side effects like hypertension and foot syndrome, but definitely they will see a better PFS benefit. And the ripatinib, this is also available in compassionate access, not available in India as of now. This has also been seen to benefiting the patients who have developed the secondary mutations. There are various mechanisms is attributed. The switch control mechanism is the one which will help us to overcome the mutation profile. So the survival, the PFS, which is there in this one is much better than 6 months. It is almost to the tune of more than 8 to 9 months. And the progression survival as well as the risk reduction is significant. So side effects profile, it has fatigue, nausea, and other side effects. This is a study where they have done along with placebo, so it is much better than. So based on this data, they have seen whether it can replace second line, and it is done with comparison with sunitinib, second line, with Repatinib, and they're not found to be better. So we, as of now, based on this data, the Sunitinib and Regorafenib and Repatinib is in the order. So other mutations which are non-GIST and non-PDA-Jafar, NTRK based pathways can be targeted with NTRK inhibitors. The data is not available on what percentage of patients are seen with this kind of mutations. BRAF mutation can be targeted with BRAF inhibitors. There is some school of thought that imatinib can be rechallenged, and participation of new clinical trials. One molecule has been very promising now. It is heat shock protein stabilizer or inhibitor, which is orally available. It is approved in Japan, which was found to be having a significant PFS benefit. Whereas there are few studies where they done combination therapy along with sunitinib. They added experimental drugs where they found to be efficient across all the mutations on the spectrum. So, and among patients who are non-KIT and non-FDGR mutated ones, they have data. They are now quite insensitive to imatinib. What we can use is sunitinib and regorafenib based upon the trials, or a new way of looking is combination therapy where they use imatinib with drugs like binitimab, which has MEK inhibitions. These combinations overcome the resistance and are efficient in this subset of patients. Most of the drugs which have been, except for sunitinib and regorafenib, are of not approved in India, so there has to be accessed in compassionate basis access, but good data to look to. So to summarize the slides, so molecular testing is strongly recommended for just to personalize the treatment for each patient. Sunitinib is currently second line treatment post imatinib resistance. Regorafenib is standard third line indications. Repatinib very promising, but is a standard fourth line. Aprivatinib is a standard of care for patients just with exon 18, that is D842 variant. The heat shock protein inhibitors have showing very good data now. It's only Japanese has approved now. And combination treatment for more complex is the thing which will be seen in future. And surgical excision should be considered for patients who have a responding disease or a stable disease in a unifocal progressive disease. Any questions? Happy to take it.
I think sometimes I'll have to genetically alter myself not to ask many questions.
I have one minute.
So, the highest PFS is with imatinib as of now. No matter, we have so many multiple things. So I have, 3 patients in last 1 year where the patient and myself, we are reluctant to move away from imatinib. Patient can afford everything. So we keep on increasing the dose of imatinib, and it's almost 1 year for all the 3 patients that with the increasing dose, every scan has 5% increase in the tumor, sometimes 10%, And I feel if you see IRACES criteria or if you see PERSIST criteria, you need to have 20% increase for you to need to change. Have you ever done anyone that type of strategy that the radiologist calls you every time, कि sir thoda बढ़ गया है ये, but you're not moving away from imatinib, patients are doing well, because all other drugs are 5 months to 8 months.
And not talking about toxicity.
And you're not talking about toxicity also. So that is something which I wanted to ask.
So I think I didn't stress on it, but there is a strong how to assess the response rate, like the density. Most of the studies have CT scan based thing, not PET scan. This is a tumor which is very PET avid. Despite that, they're not done. So there are unique things. The size increase with density reducing, it is said to be a response. I don't know how much we can sensitize our radiologists to evaluate and tell. Yeah, they have to be sensitive because this is a different behavior. We don't have options. I agree with you. So I have put a one line saying the imatinib re-challenge or imatinib continues beyond progression, additional TK. That is going to be the way future for GIST. So, next one.
So I just wanted to know if there's any data for incidence of high-grade transformation post-imatinib, and how would you treat it?
I am not. Anyone can take. Viraj is the authority in GI.
Not seen, no?
No, but what I didn't understand. But what transformation it happens?
So like a sarcomatous transformations in GIST. If anyone has ever seen that, like a high-grade.
How many of us do re-biopsy after the unilocal thing? That's the question I have.
So I think so the take home from this talk has to be after imatinib, you do sunitinib and then regorafenib. I think so the take home should be after imatinib, do a biopsy. If it is 13, 14, 15, 16, 17, you do this. If it is this, you do that. I think so that should be the take home.
Genetic testing
so
is
you
the
have to do repeat biopsy. Sunitinib and regorafenib?
No, the combination has to cover the mutation which is there. So I actually showed you there is one mutation, imatinib do not respond. There's an experimental drug which has been added and that covers exon 18, 13, one of the mutations, I think on slides are not there, is not covered by the newer, even ripatinib also.
Right, correct.
So that you can use it with other drugs. I think
is there any phase 2 data on
Yes, there is.
combination of two TKIs?
No.
not one which you are
not
using.
these two.
Not one you are using.
Yes.
Thank you.
Okay, thank you. Let's move on to the next how I treat, and this is anorectal melanoma. Everyone has seen it, but we don't have any guidelines to follow upon. So we'll take Dr. Monica's help to guide us. How do we treat anorectal melanoma?
A very good evening, everyone. Thank you, organizers, for giving me this opportunity. This is a very rare tumor. In the next 10 minutes, I'll just try to recapitulate whatever little data that we have regarding the treatment of advanced anorectal melanomas. This is a region that is infrequently inspected with minute care by either patient or physician, and some cases of hemorrhoids may not be so benign after all. These two statements we need to remember before going into the discussion. Anorectal mucosal melanoma makes up about less than 1% of all melanomas. Such a rare tumor, approximately 24% of all the mucosal melanomas. It comprises about 0.25% to 1.25% of the malignancies originating from the anorectal region. It's extremely rare. The diagnosis is often delayed because of unfamiliarity, because of a low index of suspicion. It often masquerades as hemorrhoids. Extremely poor prognosis because of the advanced stage at which it presents most of the time. And very limited data. It's excluded from most of the standard guidelines as well as staging algorithms, unfortunately. Whatever we are doing today to manage the advanced anorectal melanoma is largely extrapolated from the data that we have from cutaneous melanoma. So there's no consistent data. There's a paucity of proper data regarding the epidemiology, etiology, its biology, and very limited data to support general recommendations regarding its proper diagnosis and treatment. And unlike cutaneous melanomas, this occurs in older individuals. The median age at presentation is about 70 years. It's more common in females, again, unlike cutaneous melanoma. All mucosal melanomas are a little bit more common in females, including the anorectal mucosal melanoma. Obviously, sun exposure is not a risk factor for this entity, and it tends to be a little bit more prevalent in patients who have HIV. The biology definitely differs from the cutaneous melanoma, so it needs a nuanced view of this particular subset. If you look at this picture, it's almost like a very benign appearing hemorrhoid. So that's why the hemorrhoids sometimes which are not responding to the routine treatments, which enlarge, which appear pigmented, which ulcerate or get indurated, they, in such cases, we need to have a very low threshold for suspecting a melanoma, and definitely a biopsy is warranted in such cases. Many times they're not pigmented, they're amelanotic, and when they're amelanotic, the prognosis is said to be worse. And most of the patients have either regional or distant metastasis at the time of presentation. So a PET CT is something that we have to do at the time of diagnosis of an anorectal melanoma. Abundant lymphatics as well as a rich vascular supply around this region is responsible for the very early nodal spread. Almost 60% of the patients present with locoregional disease at presentation, and 20% of them have distant metastasis. So at the time of diagnosis, tissue has to be sent for molecular alterations, especially c-KIT mutation, which is more common in anorectal melanoma as compared to cutaneous melanomas. BRAF mutation, V600E, also has to be done, and that is less common than cutaneous melanomas. And as I said earlier, only about 1/3 of these anorectal melanomas are pigmented. The remaining 2/3 are amelanotic, and that is a poor prognostic sign. It's very important to differentiate these from anal melanomas, which are arising from the skin around the anal canal, and that has a behavior very similar to cutaneous melanomas. So it doesn't behave like a mucosal melanoma. So it's very important to differentiate between these two things. So if you look at this, it looks like a very, this is a amelanotic mucosal melanoma. They can be multifocal also, and staging of course depends upon the staging of mucosal melanomas. It follows the staging of the organ where it's happening, and but there is a generalized staging system called as the Ballantine staging system, where stage 1 is localized disease, stage 2 is regional nodal involvement, and stage 3 is distant metastatic disease. So if you look at this, this is the dentate line. They generally tend to arise very close to the dentate line, and then from there they can come outwards and present as a pigmented, fungating, ulcerated mass near the anal verge, or they can extend into the rectum also. They can extend proximally into the rectum. Now, if you look at the prognosis, most of the survival data, it predates the era of immunotherapy, but survival historically has been poor for this malignancy, with a median survival of 5 to 16 months and an overall survival of just about 15% at 5 years. Recurrence rates, despite complete surgical resection, can be as high as 50 to 90%. As I said earlier, the occult location, late diagnosis, early spread, these are the, and also probably an aggressive biology also may be the reason why these tumors do so poorly. Now, coming to the treatment, is there any role for surgery in an advanced anorectal mucosal melanoma? It's purely palliative to manage symptoms like bleeding and obstruction only. Palliative resection of distant metastasis can be done if they are symptomatic, like bleeding, small bowel metastasis can be done. And just like in the way we do in cutaneous melanoma, where if the primary is responding really well to the systemic therapy, if it's limited metastasis, we do attempt resection of those metastases. Something like that can be done even for an anorectal melanoma, but the data is very limited because of the very small number of cases and the rarity of this tumor. In about 3 to 6% of the patients with advanced disease who have clinical complete responses to immunotherapy, surgical resection of the primary tumor along with the metastasis also can be attempted, just like the way we do for cutaneous melanomas. We know that immunotherapy has revolutionized the management of melanoma. Anti-CTLA4 antibody, that is ipilimumab, as well as PD-1 inhibitor nivolumab, these are the two primary classes which are used. At diagnosis, we should evaluate the tumor for PD-1 expression also, PD-1, PD-L1 expression, because the patients who have more PD-1 expression, they tend to have better responses. However, the usage of either single agent or combination immune checkpoint inhibitors is irrespective of the PD-1 expression as far as melanoma is concerned. And the ipilimumab was the first therapy to demonstrate a survival advantage in a phase 3 trial over chemotherapy in melanoma. In this trial, mucosal melanomas were not excluded. There were a few patients who had mucosal melanomas. Of course, the numbers were very small. And the treatment for metastatic melanoma with immunotherapy supported by randomized trials, but very limited data for mucosal melanoma. So there was most of the data what we have there, retrospective analysis, and if you see, we do have an occasional complete response, partial responses, or at least stable disease we do see, and the durable response rates is somewhere around 7%, and the median overall survival of around 6 to 8 months is what is reported in most of the trials. So these response rates are comparatively low. With single agent ipilimumab, these responses are, and they could result in anti-tumor effects in patients specifically with mucosal melanoma. So this data tells us that some patients do have durable responses even with single agent anti-CTLA4 blockade. And in patients who are treated with anti-CTLA4 monotherapy, the overall response rates are quite low, but they largely mirror those which are seen with cutaneous melanoma. PD-1 inhibitors, they result in slightly better overall response rates, somewhere around 20%, and combining these two drugs gives us response rates as high as 50 to 60%. Now, hyperprogression is a problem with immunotherapy even in melanoma, particularly mucosal melanomas. They can have this hyperprogression where, if you see, this is the baseline scan, and this is after about 8 weeks of combination immunotherapy with ipilimumab and nivolumab. This is how there is a florid progression of the disease. So objective response rates of about 60% were seen with the combination, And usage of high-dose interleukin-2, interferon alpha, they are also considered as immunotherapy. In fact, they were the first immunotherapy agents that were used in the treatment of melanoma probably, but they are not being used much now, or they can be used in combination with chemotherapy, that's biochemotherapy, which I'll come to it a little later. Coming to the role of targeted therapy, as I said earlier, c-KIT mutations are much more common in anorectal mucosal melanoma, and the responses that we see to KIT inhibitors, they're mostly limited to anecdotal case reports which have shown complete responses or very good responses in an occasional 1 or 2 cases. And the series, there are small case series and the data is quite limited. So there is a phase 2 open label trial of patients with advanced melanoma with a known KIT mutation, and durable responses were seen in about 16% of the patients. So partial response or stable disease can be, it was demonstrated with KIT inhibitors in some patients, and responses in both of these trials were however limited to tumors which have exon 11 and exon 13 mutations. So sometimes responses do occur in patients with KIT amplifications also. Mutation only need not be present, and patients with KIT anomalies also have been reported to respond positively to other inhibitors, KIT inhibitors like sorafenib, dasatinib, sunitinib. In fact, there are case reports where patients have responded to sorafenib. They've achieved complete responses also. But the most important thing is that these responses most of the time are quite short-lived. Even if there is a CR, the disease comes back within no time. There is regrowth. Most of the single case reports which we have in literature, they have shown that the disease came back within a few months. So genetically selected tumors with KIT anomalies, they have better response rates to KIT inhibitors. And there are specific KIT alterations which tend to respond better, like exon 11 and exon 13. So KIT mutation analysis becomes very important, especially in anorectal mucosal melanoma. Unlike CML and GIST, where sustained responses are produced, here the responses are very short-lived. BRAF inhibition, if BRAF V600E mutation is present, vemurafenib, dabrafenib can be used along with MEK inhibitors, but mostly the data is from cutaneous melanoma. Whether the response rates will be that good and whether they'll have that advantage over chemotherapy with mucosal melanoma, we don't know. Similarly, role of chemotherapy, the response rates to any alkylator based like temozolomide or dacarbazine based chemotherapy regimens has been historically very low, much lower than cutaneous melanomas. So biochemotherapy is something where we combine chemotherapy drugs. There are trials that showed combination of dacarbazine, vinblastine, cisplatin along with interleukin-2 and interferon alpha, where they showed response rates to the tune of about 10 to 15%. So there are good case series for this biochemotherapy. And so basically ever-evolving intricacies of tumor pathogenesis and complex mechanics of our own immune response. So maybe combination of targeted therapy with immunotherapy is probably the next step. And the only way to reduce the devastating morbidity and mortality of anorectal mucosal melanoma is to lower our index of suspicion. So the key takeaways are that it's a rare malignancy. A very high index of suspicion is needed to diagnose it early, especially in seemingly benign hemorrhoids. There are no standard guidelines for the management. Molecular profiling with especially to look for BRAF and KIT mutations is very essential before commencing any systemic therapy. Single agent chemotherapy, combination chemotherapy, biochemotherapy, and immunotherapy, the single agent or combination. These are the various treatment options that we have. And combination immunotherapy is always the preferred first line wherever it's feasible in the absence of BRAF or KIT mutations. Biochemotherapy has a higher toxicity and lower response rate. So as of today, we don't have any biomarkers to identify which of these patients will actually respond better to which of these treatments. So trial and error strategy and sequencing all these available options one after the other depending on the patient's condition is what we can do. Thank you very much.
Thank you, Dr. Monica. In the interest of time, we'll move ahead just to make a point that we have Indian data of 10-year experience of treating mucosal melanoma from Vellore, and I urge everyone to go through that, where they have used 50 patient data, where they've used immunotherapy plus TKIs in various combination. Let's move on to the third, how I treat. Now, this time, small cell carcinomas of GI tract origin. We commonly see small cell advanced esophageal cancers, gallbladder cancers, rectal cancers. And to tell us more about this, let me introduce you Dr. Manu Prasad. Please,
Good evening all, and first of all let me thank the organizers for giving me this opportunity. So I'll be talking about how I treat advanced gastrointestinal small cell carcinoma. So coming to the incidence, this is a rare neoplasm, though we encounter this tumor in our clinical practice. So historically the incidence is 0.1 to 1% of all GI cancers, and most of the previous papers say the most common site is upper GI, and the preponderance for elderly males, and majority presents with regional nodal involvement. And more than 50% of these patients can have metastatic disease. And generally neuroendocrine carcinomas include large cell and small cell. Now here we'll be mainly talking about the small cell. And though I've mentioned that upper GI is the commonest site, recently a paper based on the SEER data says colorectal cancers as the commonest in the series. Around 30% were colorectal, and also equally esophagus, pancreas, hepatobiliary, and stomach small cell carcinomas were reported. And the first question is like, is it the same disease as small cell lung cancer? Do we need a separate discussion on this? Answer to this will be a no, because there's a lot of differences between these cancers. So first thing is, unlike small cell lung cancer, the strong association smoking is not proven in case of extrapulmonary small cell cancers, including GA. And another difference is in the incidence of brain mets. So these cancers have much lesser incidence of brain mets compared to the small cell lung cancer. And genetic landscape is also different. I'll come to it later. Based on the regions, the genetic profile can change. And the response to platinum is also not as good as the small cell lung cancer. So there's a lot of, there is a significant positive data. All the decisions are based on the retrospective evidence and extrapolation from the small cell lung cancer. There is some data on the GI neuroendocrine carcinomas in general, and there is a guidance paper from the INET Society published last year, which can be a reference document. So when we come across such rare tumors, the most important thing is to have a proper multidisciplinary tumor board discussion, because a lot of confusion can happen starting from the diagnosis. So diagnosis is the most important aspect, and it is basically a morphological diagnosis. And we have to rule out lung primary. It can be done by imaging. Sometimes IHC can be helpful. And another class differential is the neuroendocrine tumor grade 3. So neuroendocrine carcinomas are different in terms of they are characterized by the lack of typical organoid pattern seen in neuroendocrine tumors. There will be a lot of necrosis, and also the mitosis will be more than 10. And Ki-67 cutoff is always controversial, and most of these tumors will have a cutoff of more than 55%. And we have to be aware that in small cell carcinoma, the chromogranin may be negative, especially in small cell carcinomas, and sometimes the markers like ANSM1 can be helpful. So coming to the staging, this is one of the cancers where PET scan is strongly recommended, because these are highly aggressive tumors, and more than 50% of the patients can have metastasis. And also it's also important to rule out a lung primary. And in GA cancers, we do endoscopies based on the site. And another question is, should we do a routine MRI? Because the answer is no, because the incidence of brain mets is much lesser compared to the small cell lung cancer. And one series reported brain mets less than 5%. And routine bone marrow study, that is also not required. Only if the counts are abnormal, we can proceed with the bone marrow examination. And this, in its guidelines, also recommend an FDG prior to starting adjuvant, so indicating that this is such aggressive disease which can progress during the interval period itself. And coming to the treatment part, for the locoregional disease, the principles are same as any other GA cancers. They should be considered for surgery except for esophageal stage 3 and anal neuroendocrine cancers. And there are retrospective evidence saying that these patients can have survival up to 30 to 40%. And many of the series say those who underwent surgery had a better prognosis. So in the graph, we can see those are the local disease, the survival is around 40 to 45%. For locoregional, it is 20 to 30%. And when it comes to the distant patients with metastatic disease, the survival is dismal with 2 to 4%. And in case of esophagus, as already mentioned, instead of surgery, chemoradiation should be preferred. And there's a small study which says that the OS is much superior for the patients who received chemoradiation, that is 45 months versus 12 months. And this is a neuroendocrine carcinomas in general, but around 60% were small cell carcinomas. And adjuvant chemotherapy should be considered after radical surgery for digestive neuroendocrine carcinomas. That is also based on the retrospective evidence. And current data suggests platinum etoposide adjuvant treatment 4 to 6 cycles. And in selected patients, we can go for neoadjuvant chemotherapy if the surgery is going to be very morbid. Coming to the extensive stage disease, so this is one of the solid tumors which warrants rapid workup and initiation of treatment, because these are highly aggressive neoplasms and they can progress and resulting in the decline in the performance status. Finally, patient may not be eligible for any major anti-cancer treatment. And all these studies have shown that performance status is a very important predictor. And as per the literature, the median survival without chemotherapy is only about 1 month. With chemotherapy also the survival is around 9 months, and this is based on the SEER database data which include all stages of patients. And most of the studies have used etoposide platinum 4 to 6 cycles. So these are the multiple retrospective studies mainly in neuroendocrine carcinoma. So you can see the response rates is around 30 to 50, and PFS is around 4 to 5 months, and OS is around 12 months. And one striking thing is that patients who progresses during the first line treatment, that is up to 30%. Generally, solid tumors, this rate is around 10 to 15%. Here, around 1/3 of the patients can progress during the first line treatment itself, indicating the aggressiveness of this disease. So, small studies were undertaken to see if there is any better regimens than EP. So one was irinotecan instead of etoposide. There was no difference. Then carboplatin was used instead of cisplatin, though no difference in the outcome, but we know the toxicity part is better for carboplatin, so we can definitely make use of carboplatin in patients who are not eligible for cisplatin. And another study looked at scheduling of etoposide, whether it is oral or IV. And that also did not show any difference, but oral, there's a trend towards a shorter overall survival in oral etoposide. And lesser toxic alternatives like capecitabine temozolomide, it can be tried in a select group of patients if the Ki-67 is between 20 to 55%. So such groups may benefit from a lower intensity treatment. And we don't have evidence for the first line itself, and subsequent lines, nothing to say. There is no evidence, no standard. So being GA, we can make use of 5FU or irinotecan oxaliplatin based regimens, and those with the Ki 21 to 55, we can use CAPTEM. And if the PFS, if the treatment-free interval is long, we can actually, some issue with the formatting of the slides, I think last line is not seen. And if the PFS is long, we can use platinum as a retreatment. In the second line setting, the response rates are only 10 to 30%, PFS 2 to 4 months, and OS is around 5 to 7 months. And what about immune checkpoint inhibitors? We have data in the small cell lung cancer. Can we extrapolate it here? But we cannot do that because there's 2 small studies that looked at immune checkpoint inhibitors in GA cancers. One was used nivolumab combined with carboplatin etoposide followed by nivolumab maintenance. Small 30 to 38 patients, and majority had neuroendocrine tumor. And the response rate is 54%, disease control rate is 84%, but PFS was still around 5.7 months, and only 40% of the patients were free of progression even at 6 months. And single agent immune checkpoint inhibitors after platinum etoposide, very low response rate. And the combined PD-L1 and CTLA-4 has some efficacy. The response rate are around 10%, and 9 months survival is around 36%. So immune checkpoint inhibitors have a very limited role in this subgroup. What about the precision medicine? What about the molecular testing? So as I've already mentioned, these are genetically different from the lung cancer. These tumors are characterized by P53 overexpression, high proliferative activity, BCL2 overexpression. Another thing is RB inactivation and KRAS mutation, P16 loss of expression. And if you look at the subsets, esophageal neuroendocrine carcinomas are more similar to small cell carcinomas. Then the colon primaries, BRAF, APC, and KRAS mutations are very frequent. So in BRAF incidence is around 50%. Actually, it's one of the cancers after initial one, thyroid, which has highest BRAF alteration. And microsatellite instability, that is, the incidence is very low. It's only 5%, and that too in association with the BRAF 600E mutation. And another thing is tumor mutational burden. That is also low. Its median tumor mutational burden is only 5. So we can get a molecular analysis. We may be able to offer BRAF inhibition in a select group of patients, and rarely targetable mutations like KRAS 3%, RET 3%, NTRK 0.3%. This can be seen very rarely. And the loss of RB is found to have some relation to the response to platinum. So it is always better to go for a molecular testing. And prognosis, as I've already mentioned, is very dismal. And median OS is around 9 months. In this study based on the SEER database, the prognosis is better for small intestinal primary. So 3-year OS was around 20 to 30%, whereas it is worse for the pancreatic primaries, where the 3-year OS was 5 or 6%. So chemotherapy, surgery, RT, female sex, age less than 65 years are associated with the superior OS. Advanced stage, hepatobiliary, these are associated with poor outcome. So to conclude, these are aggressive cancers with poor prognosis. These are different from small cell lung cancers. And during the work, establishing a definite diagnosis is very important. And FDG PET is strongly recommended to rule out distant metastasis and to rule out a lung primary. EP remains the first line treatment. We can use carboplatin if the patient is not fit. Immune checkpoint inhibitor is only a limited role. Molecular testing can have a role, at least in a select group of patients. But all these are based on the retrospective evidence. We need to generate prospective data so that we can take better decisions for our patients. Thank you.
Thank you, Dr. Manu Prasad. Any questions? Do we have time? Okay, we'll move on to the next. I think we are like a couple of sessions away from our oration, and let me invite Dr. Vikas Oswal for the next moderation. And he's going to discuss about a very interesting topic about how to collaborate for research. Considering that Vikas works at TMH and he is doing extensive research, but he is going to discuss about the rare GI tumors. And Vikas, and let me invite the panelists, Dr. Chetna Bakshi, Dr. Anup Tochniwal, Dr. Gunjesh Kumar, Jaideep, Dr. Rakesh, and Dr. Shailesh. So Vikas, you have half an hour for this session.
That's a lot. I think I want to thank organizers for selecting this topic. This is the need of time. You heard so many topics, so many presentations. Every topic is either retrospective data or a case series or some small phase 2 study. That's fine. And I think you should understand, if you look around, that is the situation in our country. There are hardly any people here, and hardly any trials, and hardly any collaboration. That's the situation. And those who are left here probably are interested in doing a lot of things. So that's great. So let's make it very interactive. And I didn't know what to talk about this. And maybe let's start with panelists to highlight what is the definition of a rare tumor. Do you have any particular definition on your mind, or you have any consensus on a particular definition of a rare tumor?
Hello, can you hear me?
Yes.
So that's what I was going to say. The first thing for collaboration, we should have a definition, right? So in Europe, I think they are saying it is 6 per 1 lakh population is the definition, which in India should not be there. We have less incidence. So I mean, it's very arbitrary, but I think it should be 1 per 1 lakh should be good enough, I think.
Oh, that's a wonderful answer. I think 6 is something really not reasonable. But let's hear the other panelists. One more comment and maybe we can move on this.
I think any cancers which has got a less than 4 to 5% incidence across the board of all the GI cancers, I would call it as rare. And also common cancer with an uncommon genotype can also be called as a rare.
That's wonderful. So I think I looked at this multiple definitions. So Europeans and UK guys think that 6 per 100,000 patients diagnosed in a year would be a rare cancer definition. But the others think that it could be 2 per 100,000 patients diagnosed per year. Now, would you like to agree on this definition of 2 per 100,000, or as you already said, Dr. Bakshi, you already said 6 per 100,000 is not something which we should consider. 2 is something useful, or you still want to go down? Anyone can talk about it.
So as I already said, I think it should be 1 per 1 lakh. That's what I personally feel.
Right.
There was a paper by Dr. Jyoti where she has used 3 per 1 lakh as a cutoff for the rare cancers.
We'll be discussing on that part. So we do not have any data from India, and I was looking at this networks, and we at TMH we have rare tumor board, and lot of rare cases are discussed. Akhil is here, and there are many of people who are part of this rare tumor meetings and discussing the rare cases. If you look at this European reference network, they were looking at the rare tumors, and then adult solid cancers were looked by Eurocan. They also started teleconsultations for this patient so that there could be a central teleconsultation or central data or analysis or central treatment for these patients. Would you, do you think that this kind of teleconsultation or this kind of network in our country, is it feasible? Is it possible? And would people agree with this?
If TMH, I mean, we can send the patients to TMH. Only thing is we should have a proper list of the cancers which we put into a rare cancers, right? Once we have a list, if we see those patients, we are okay to send to Central Expertise Committee.
Right. Any other opinion? Yes, sir.
I think the problem starts with the diagnosis. You know, if it's a rare tumor, at least in Tier 2 city where I work, the problem starts with the diagnosis, whether, I mean, is the pathologist able to make that diagnosis of that disease, then everything else is okay. I mean, we all are, I mean, everybody would be more than happy to have a tertiary care center opinion for a rare tumor. You know, but the problem is this.
Yes, I know.
Sir, there are online meetings all the times which are happening once a week, once in a month or so. So it is already existing. I know of certain doctors who present rare cases or common cases with rare comorbidities and presentation. So there is there, but it is not very formalized, structuralized yet, and there is no proper way of presenting of this tumor also. There is no list, there is no prospective Excel sheet or data sheet is maintained. So that is there where we can do much more.
So Vikas.
Yes, sir.
Yeah. So it's a great idea to have the tertiary referral centers for rare tumors. The only issue is, I mean, just giving the example of Tata Hospital. I don't take Tata Hospital as finger pointing, but there should be established communication. Sometimes it so happens that the patient goes to a tertiary referral center. Let us say, for example, Tata Hospital. So, who examines the patient, who opines what, on what basis, what were my questions, whether these questions are being adequately addressed or not, whether they are communicating back to me appropriate or not. But these all things need to be established before establishing the tertiary referral network.
I agree with you, sir. And I was coming to that point.
But Isme, I think teleconsultation should help, sir. Like if, for example, if I'm in Thane and if he's in Tata Hospital, if I have a patient, if we have some particular date, you know, I mean, this date there will be a rare cancer ka tumor board, then I can have a teleconsultation on that day.
There has to be established way of communication. So that's the point which I want to make.
Yes, that's true.
So, sir, in TMH we have a rare tumor board WhatsApp group. I am also there, and we are able to discuss our rare tumors in that OPDs and in that discussion. So we are doing that, sir. But the problem is, yes, sir,
Right.
that should be accessible to other clinicians also. Yes.
So this information we did not know, even though I am in Bombay. So I think that is what is more important, that this information everybody should have, that there is such tumor board in Tata. I did not know till now that there was a rare tumor board in Tata Hospital. Yes. So if we know that, then it is easier for us to access and to talk to the people.
Yes, this is going on for last 2 years. I think I've been part of it. The point was this. I wanted to show this slide. There are so many institutes involved in this network. I don't think that we should be referring patient to a particular tertiary cancer center. Even we don't know how to treat these patients. Ideal would be to have a collaborative work together, and we have all the medical oncologists who are treating this rare tumors. Most of them will come in a metastatic setting, but yes, we can have everybody on board and have a way of treatment, and then we can have the trials going on, or trials conducted based on the experience of treating these patients. I don't agree with the point that we should bring all the patients to a particular tertiary cancer center and then, you know, they are lost in the middle of the common cancers. And that's the whole idea of this network. And you know, they do not actually bring all the patients together, but they have a good telecommunication and consultation, and the treatment becomes kind of uniform, and the treating physician remains the primary treating physician. These are the tumors they have added. I'm coming to GI obviously, but these are the tumors they have considered, and out of this small bowel adenocarcinoma and obviously squamous carcinoma anal canal which comes back. We see a lot of squamous anal canal and we know how to treat with ctRT, but then when they come back we don't know what to do. They do not respond to any treatment, and we have seen many of these tumors, when they come to us or to any of the physicians, there is always a reference given to a particular retrospective study or case series, and they are treated according to that. So there is no uniformity in the treatment. Now, do you want to add anything to this list? And now let's move on to focusing on GI tumors, which we have already heard. And Viraj had already chosen nice topics, and then we had an extensive discussion that there is no data. Do you all agree, or do you all think that we should have a particular registry or initiative? It should not be like coming from a particular tertiary cancer center. It can come from anyone. And registry is not, which I am talking about, just adding demographic data and then the patient is lost. Registry should be starting from the demographic data, treatment given, outcomes, and follow. Then we will learn from that. So any thoughts, any way how we can consider a particular registry for rare GI tumors?
Not only the prospective data should be maintained, there should be, if feasible, also a tissue bank. Suppose patient has succumbed, we should request the patient that block has to go to central tissue bank, and suppose 3 years, 5 years down the line, if we have ample amount of cases, then a CGP genomic profile can be done for rare tumors, and even blood can be archived for those patients. So that is one of the suggestions for if we do something like this, we can have data for rare tumors.
Wonderful. I think one point I would like to highlight here, that what is rare for the Western population is not rare for us. The best example is gallbladder cancer versus cholangio. Now 80% of their tumors is cholangio. When I talk to them, they say Europeans do not even see gallbladder. If you present or submit your data to Europeans, they would say, what are you talking about? Nobody will come near your poster or your presentation. And when we see gallbladder with 80% and 20% cholangio, I think that it should be based on the region, it should be based on the tumor, and there will be one more addition. So do you think we see, say for example, now cholangio, as you see, there are about 12 FGFR inhibitors, and we have second line FGFR inhibitors which were just presented in GI ASCO. Do you see cholangio in your practice? And as an example, would you see, compare a data of number of gallbladder cancer seen versus cholangio? Maybe Joydeep can look at it because he sees a lot of gallbladder cancers.
We do see cholangios, and most of them are intrahepatic cholangios rather than extrahepatic. And whenever we find a cholangio, we tend to do the slide block review from 2 established labs so that we are not missing out on an HCC. What was your second question, sir?
So if you compare in your practice the gallbladder versus cholangio, what would be the proportion?
Talking of the metastatic disease first, we would treat it just like the way we would treat
No, the proportion, the number of patients seen in your practice.
Definitely much less. Cholangio is much less compared to gallbladder. I would say in my practice it's 90% gallbladder and 10% cholangio.
So if we have a registry, my question is, if we have a registry, would everybody agree to a standard uniform diagnosis, investigations, treatment pattern? Because diagnosis of cholangiocarcinoma is a diagnosis of extrusion. Now you have to do multiple, at least you have to do PET or symptom directed endoscopies to rule out the other side of metastasis. ISC may not tell you anything. It can be from stomach to biliary tract to small bowel. It can be all CK7-19 positive, and you may not have any differentiation. So when we talk about registry and the initiative like this, do you think many of the medical oncologists or our oncology colleagues would agree to a uniform diagnostic pattern and investigations?
So 2 things. Definitely, yes. For bigger centers, this will add on to their data set. As a whole, we will be having data of our own country. And secondly, even for smaller centers or individual practitioners, if we can tell the patient that your treatment is being decided by a consortium of medical oncologists sitting from 5 top centers, that gives them more confidence on the treating doctor than, you know, that person deciding the treatment.
Right, that's a very good point. And Anup, do you think that we ask for a PET, we ask for endoscopies, do you have a fear of losing the patient? So you have a question.
Yeah, I was going to ask you, every oncologist doesn't have to agree. Even if there are 10 people who agree, that is good enough. And whatever information they provide, the registry will have benefit.
Yes.
Yeah. So you might have a common minimum, must have, and then good to have. If you have 2 groups, and then whoever contributes is fine. Because now our oncology community in India is in thousands.
Yes.
And we can't expect everybody to agree to that. But a handful is enough here to do whatever you are interested in.
Thank you for this comment, sir. And would you be worried about you are in a private practice, and would you be worried about losing the patient because you are asking investigation after investigations? And
so, sir, to be very true, that is one of the factors sometimes. If you look at the socioeconomic profile of the patient is not well to do. Patient is from a rural area. It is difficult for him to come to even center where I practice. It has become difficult for them to investigate in very details. So you have to look on case-to-case basis of how we want to investigate. Obviously, real-world issues are different, and what we are talking here, standardization of data, is different. But that might be one of the factors when we want to implement these things.
So would it help to have this registry or common pool of medical oncologists discussing the case, and as Joydeep mentioned?
It would, sir, but there will be some counterintuitive issues also, because then what happens is sometimes patient might think this is a very difficult cancer and this doctor is not sufficient. He will keep on jumping to another doctor also for second, third opinion, and then later for every small decision, like for treating febrile neutropenia, he might ask your consultant what antibiotic to give. So that is a practical issue.
Yes. Any other practical?
So one of the point which
like suppose you are in a tertiary care center and suppose you had given some answer to your patients that this is a rare tumor. The point is, whenever patient goes to another oncologist also, if your colleague is also giving the same answer, that it is also right, that previous oncologist is also right, that it's a rare tumor. Like suppose that Aurangabad patient going to Nasik and Nasik also telling the same. I think the most of the patients are coming back to you. So I think we have to stick, like Dr. Vikas told, that this is a rare tumor, and sometimes that patient is also telling us that, sir, the previous oncologist is also telling the same thing what you had told.
Yes, sir. So I agree in principle. I'm just telling what can happen on side track and just.
So one problem in that is that you will agree majority of the patients search their doctors in Google and not into forums like this where people are talking. So that is one major problem.
Do you see any medical legal issue or ethical issue discussing the patient? Suppose, Kunjesh, you have a patient in Ranchi and you are discussing in a common forum. Obviously, they all are doctors, but you have any hesitation in adding your patient to the registry, discussing the patient on the common pool, or any issues you think it could be a problem?
Adding a patient to that registry is not an issue, sir. What I face that starting from beginning, that my radiologists sometimes are not very able to give me proper tissue diagnosis so that I can further go to further IHCs or molecular diagnosis. Sometimes we exhaust our tissues. So problem starts from there. Also, again, like sir told, that I usually face that if patient is having delay in diagnosis, then problems starts from there. That doctor is not able to diagnose this case, and that's why usually they shift to either to CMC Vellore or TMH Mumbai. What usually I face, sir. So this is a very common issue in my region. There is no issue in adding our patient in registry, sir, but these logistic issues is very common in my region.
Sir, if written informed consent is taken, I don't think there will be an issue of adding the chain. It might be anonymous.
Right.
I think we should have a bare minimum requirement to come to a conclusion, because you can't have all high-end and whichever best possible investigations to have it diagnosed and then planned, because not all patients will go for it. For example, like
Anup was saying, those patients who have already got a CT scan done, because PET scans are not available in government setup, but CT scans are. So it's already a metastatic disease. What additional information you're going to get by doing a PET? So I think these bare minimum investigations, if we have, I think we'll be more than happy to have more and more patients.
So the bare minimum investigations can be set up with a kind of a teamwork. So if you think it's a CUPS and you want to rule out it is intrahepatic cholangio versus a metastasis from a colon, which is a primary is asymptomatic, I think the PET or the symptom directed endoscopy would be important. And I don't think that cholangio is so rare in our country, but we are missing on it. And the treatment would differ. Somewhere you will give Capox and somewhere you will give Gemsys. That's like entirely a different set of treatment. Looking at that, moving ahead, I came across, so setting this stage and understanding that, okay, there's a welcome thing, that mentality is there, that thought process is there, that we need to have a registry. This was a paper which Madam was talking about. I think Sharda and our team have published this in Lancet Regional Health, Southeast Asia. Why I want to discuss this paper, because this is the only thing which talked about the rare cancers in our setting. It talked about South Asian, but mostly the data is from India. I want you to have a look at this data, this chart, or maybe this diagram. And if you look at, let's start from the north and central India, where the incidence of cancer, like oral cancer, is less than 6 per 100,000. Would you agree to put that oral cancer into a rare tumor subset? Coming down to less than 3 and less than 1 and less than 0.1. Dr. Bakshi, what do you think?
That's what I said. I mean, according to me, it is only less than 1 I can put into a rare cancer category.
Wonderful. Joydeep, what do you think? Your zone, east and northeast. Less than 1.
So stomach cancer, obviously if we look at less than 6, stomach cancer, ovary cancer, these are very common. I mean, we all know that. So less than 1, I would say. I don't know why they have put uterine cancer also in less than 1. Obviously it must, data-wise it has come, but it is very common.
So do we need to go down to less than 0.1?
I think so. Yeah. By this data, if you go, definitely.
Okay. Anup,
very robust. It's an Indian registry. It is captured might be from 1 or 2 centers.
No, it is captured from multiple registries.
But still, sir, it is not. It might not be homogeneous data, because you know how there is a lot of disparity in even cancer centers in a developed state like Maharashtra. You go to interiors. I don't think this is a real data is not captured properly. It cannot be correlated with the European guidelines. Cannot be implemented for us. The population is huge. You don't have adequate resources to capture all the data.
Shailesh sir, you agree or you differ?
I just have one query. Sorry for my ignorance. Is cancer reportable now? Any update on that, sir? Sir, Purvi sir can update on that.
So I can give you an update on that, the reportability part. State health is a state subject. So there are 5 or 6 states in the country where it is mandatory to report. And Rajasthan, since the past 2 years, my state, we are mandated to report every diagnosed patient of cancer. And there are 5 or 6 other states which also have this law in place. So, but it's not a central thing.
So just to
Jharkhand also started considering cancer as a notifiable disease in last 6 months before.
I go to visit to my native place, Hingoli. It's a backward area. Lot of patients I diagnose, I treat, and the patient succumbs or get cured, and they are just in Hingoli. They are never captured by this data. And the Hingoli population will be calculated as in denominator. So it is not a proper representation of data.
So we all agree that we definitely need at least a registry for rare tumors to begin with, and maybe we can look at the kind of national level and common cancers and all that. If you just to make a comment, the gallbladder is considered as kind of under 6. It's 3.7, and we see so many. But do you also think that there is a referral bias? We have a tertiary cancer centers, we have oncologists, at higher centers, and then they see a particular cancer, and that is considered common, and maybe it may not be that common. So just to keep in mind that we should not get biased with the referral center. We see so many rectal cancers, but we see less colon cancers. Now, is it because colon is lesser than the rectal cancer, but the colon is operated outside, it is easy to operate? Rectal cancers are referred to a particular center, higher center, because multimodality is required. So that is also to be kept in mind. Now, going ahead, we discussed these cancers, and I mean, obviously, do you have any other thing in your mind that we should add to the list?
So small cell of gallbladder.
Small cell of gallbladder, small cell, yeah. And we just saw one interesting topic, as you mentioned about small cell carcinoma. A lot of people started extrapolating the small cell lung cancer data and added durvalumab maintenance therapy along with chemo. Would you agree to kind of extrapolate this data? Melanoma, anorectal melanoma, mucosal melanoma, IO, I have not seen a single patient benefiting with IO. Keep giving IO because of the extrapolation from the cutaneous melanoma. So is it possible to extrapolate the treatment? And that's the reason I wanted to highlight this list, and please add to this list. Keep in mind that it's not just a small list of 4 to 5 cancers.
Small intestinal malignancies also should be there, because we don't see much small intestinal cancers.
Yes, they are rare cancers. Well, again, the diagnosis of appendicular cancer is missed most of the time. It would be a peritoneal disease, and in a male patient, and you will have cups. You will be treating with K-pox, but you don't know whether it originated from the appendicular cancer. That's very important challenge we're going to see when we look at the rare cancers, especially GI rare cancers, because abdomen is a magic box. And moving ahead, do you agree with this kind of classification? Now, I am not looking at the site-based or organ-based, but I want to look at this kind of classification in GI cancers. And would you label these based on these markers as a rare GI cancer, and like to do or like to have registry, as Anup mentioned that we should have a tissue? So, thought process.
It is very difficult to categorize, because what kind of panel you are using. So for example, HER2 you are using by IHC, or you doing on NGS. NTRK fusion is plain, or NTRK is with TP53. FGFR is there, FGFR is with other co-mutations. How will you do? Then MET amplification is, what is the cutoff of MET amplification? So then it has to be more detailed of this, and then again we are looking at DNA, and then what happens to epigenetic data, then what happens to the microenvironment of the tumor. So all those things also, and then what is the histology of the tumor. So this might be subset of the data, but then it has to be more comprehensive.
Okay, interesting.
I think we can get that centralized, send the blocks, and you can have it at the central area.
Right. Any other? Joydeep?
We can add KRAS to this list.
Yes, it's on the way. So, so but again, so I was part of this basket trial or NTRK fusion. I searched for the NTRK fusion, and so many patients were evaluated, but I could not recruit a single patient. When I found a patient, that the trial was the one patient who had performance status 3 was allowed. He was performance status 3.5, 4. And when I found another patient with NTRK fusion, the trial closed the recruitment. Now, this is a problem, but would they benefit? Yes, if you use larotrectinib, the response rate, the benefits are significant. So if you want to make a difference, if you have a basket trial, that is one basket trial. You can look at the other basket trial is FGFR mutations. You have pan-FGFR inhibitors and specific FGFR inhibitors. Also, if you have a patient with you have a kind of a registry, you're going to collaborate, and you're going to have a basket trial. Would it be useful when you have a particular target and the drug to target and have significant response rates and survival benefit? Would you agree now when I say that about the improved survival benefit with the targeted drug to particular targets? You're going to change the life or lifespan or make a significant difference in these patients. Now, just to give a background, see NTRK fusion is very rare, less than 1% in colon cancer, less than 1% in gastric cancer, but it is 1 to 2% in melanoma, 1 to 2% in GIST patients, neuroendocrine tumors. All 2 patients I found in neuroendocrine tumors. So, would you see these are the rare tumors, and now you have a rare marker, but you have a very effective drug. So, would you not consider molecular based classification and registry of this?
So only if the drug is available for the patient.
Sir, but what happens, suppose ALK positive CA lung, you treat and you treat a ALK positive ALCL, they will not behave same. So that has to be kept, the BRAF in colon will not behave as BRAF what is in lung. So that has to be taken into account.
That's a very important point. We cannot extrapolate all the time, and we cannot get the similar results when we have the marker present in lung and marker present in cholangio. I had a patient with MET amplification, and a patient was also willing for everything, and all. It was a cholangio, intrahepatic cholangio progress on GEMSIS, and willing for everything. A patient with IDH1 mutation was willing for everything but couldn't get the drug. So availability of drug is also very important. Compassionate ground program or compassionate based importing the drug, and all those were a lot of issues. MSI-High is definitely a marker which I would say it is not based on a particular cancer. I mean, as a site, I would like say tumor agnostic. The basket trial of MSI-High patient benefited in all solid tumor I'm talking about, benefited significantly with immunotherapy. So, do you see all these kind of markers and the basket trial is feasible in India or possible in India?
Only problem will be the cost constraints as told by others, because getting these drugs by majority of the patients won't be able to afford it if we have to import. That will be the major concern, sir.
Right.
Rather, if we have a trial designed from TMH which would look at role of metronomic in situations where we cannot do anything and classify based on these and see whether which particular mutation actually responds to it or doesn't respond to it, that would add to some extent.
Right. So, cost is a problem, but when we have a registry and we can ask for funding, and we have a rare tumor registry and we can ask people to intervene, and obviously if someone is NTRK fusion positive or MSI-High, probably we can benefit significantly. We can ask multiple NGOs to support. I will just go through this kind of multiple trials. We already discussed there could be a registry, there could be a surveyed Delphi consensus, basket trial, multi-arm, multi-stage studies, and phase 2 trials, because phase 3 are difficult. I'll just give one example of this trial which was based on a Delphi consensus. The point highlighted here is that there was so much of variation in the practice that the consensus lead to more confusion. So I don't think consensus is something which is useful in this rare tumor. And as we said, we're going to have multiple people treating differently, and then it's not going to make sense to anyone. Multicentric phase 2 trial, this was one trial which I looked at, and this it is commendable, but you see over the years of 6 to 7 years, they could recruit 60 centers, 91 patients, phase 2 trial. These are the efforts. Can we do it in India? Do you think, is it possible, feasible?
Definitely, sir. Definitely, if we work in collaboration, definitely it seems to be feasible, doable.
So this was the chemotherapy trial, and second line therapy in gallbladder. This trial we did. Why I highlighted this trial was Anant is first author from TMH. Dr. Atul Sharma is part of this. This was the first collaborative trial we did, and when I did this trial design, I was told that it is multicentric collaborative trials are not feasible in India, and I wanted to challenge this, and this worked. And then we went ahead and we asked, we did this marker based study, and we could recruit 90 patients which are HER2 positive in gallbladder cancer, mostly gallbladder cancer. Now there are 3 trials which were initiated before this, and they closed the recruitment because of the poor patient recruitment. Now, I'm not saying that we have the capacity if we have multiple centers involved. We had Tata, Mumbai, we had Homi Baba, Varanasi, Akhil is here, and this was possible because of the collaboration. And the last part is it possible in curative setting, not only in metastatic setting? This was a trial we did in adjuvant setting, again in gallbladder post-op, how many gallbladders get operated, but we could complete this phase 2 trial, and there again 3 centers were involved in this. Now somebody would say probably only 3 TMS centers are involved, and there is no possibility that we have other centers can be involved, but that's not true. I have just given one example that this was a gastric cancer trial, but we had Dr. Biswas from JIPMER and the other 2-3 centers including Varanasi were involved in this. So the trials are feasible. Why I brought this point that it is not impossible to do multicentric collaborative trial. So when we have a registry, we have a similar mindset, and there is that we can have multiple PIs at multiple centers who can work together to bring the result. So my question to the panelists, last slide of my presentation. Do you agree with the able and willing, or do you think that we are still in unable and unwilling situation? Gunjesh, Joydeep?
Able and willing, sir. We can do that.
So, any other comments?
Definitely, sir, able and willing, but in some situations you inadvertently fall in the unable but willing group.
That's very important point, and I thank Dr. Purush Parekh and Viraj for choosing this topic. And I think this is something where we should come together, not the usual medical conferences we talk about the copy paste of the data, and we can do it. It's not that it is not possible. We have done a small 90 patient or 100 patient trial, but if we all come together, we can definitely a neuroendocrine tumor. How many of you can say that you have not seen a single patient in your practice? You definitely see. Now, neuroendocrine tumor is so common that we can finish a large phase 3 randomized trial with all collaboration. And it is not a difficult job. I'm sure it will require efforts, but we can do it. Thank you.
Thank you.